gavel down, and I want to go ahead and call the meeting to order. And first of all, good morning and welcome. Oh, and I'm not, and I've already not pressed the right button in terms of so. We'll get there. It's been a long time since I've chaired a board meeting, so I just want to say good morning and welcome you all. Our meetings will continue to be hybrid as they have been, and healthcare authority staff will be on site, and board members and other attendees have the option of attending on site or via Zoom. It's great to see those of you that are here in person. For our members of the public attending via Zoom,
this is right.
About turn on. Let's make sure we have that on. How attendees can turn on closed captioning subtitles. Also, public meeting attendees will only be able to activate their audio and or video during the public comment period at the end of the meeting. At that time, participants will need to raise their virtual hand and only after being recognized by HCA staff, and will the participants see the ability to turn on or off their audio and video options. I hope all that's clear. I just want to do some board member introductions right now. We'll do a roll call to identify board members that are with us today. First, Harry Bosley, Elliot Weinstein, Mikaela Bowman, John Comerford
here,
you, and then virtually Sharon Lang
here,
Kurt Spiegel,
present,
Tom McRobert
Here.
great, and also we have Michael Tunick from the AG's office.
Here.
And again, I'm Mary Ellen Glad, and the Healthcare Authority Interim Director and the Board Chair. With board members attending both in person and virtually, it would be helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are questions. Board members attending virtually excuse me, will also watch in case you use the Zoom raise your hand feature to indicate you have a question. There will be no resolution scheduled for action at today's meeting. The public will be able to provide general comments at the end of the meeting during the public comment period. And just as a reminder, if the public has questions during a staff presentation, the presenter's contact information is included at the end of the presentation. The public is welcome to email presenters during the meeting to capture your question for a response after the meeting. And now Dave Eisinger will be providing an overview of today's agenda.
Good morning, Chair Linda Blatt and members of the board. We always start off our meetings with a little bit of time travel, asking you to finish up a review of some minutes. We don't usually have you vote on minutes at the retreat, so the last couple of meetings from last season and then the retreat. I have a follow-up presentation with a couple of answers about UMP Plus and that proposed plan closure in some of the proposed budget documents that have come out so far. And at that time, I'll also give some remarks about the current network disruption notifications that are out to members involving Providence, Swedish, and PEBB. We will have a legislative update. There are legislatures in town where bills are, where what bills don't exist anymore. So Kate will be us for that. Tanya and I will then go over budget reduction options. These are budget options that were published on OFA's website after state agencies did a variety of work to identify possibilities for reductions to assist with the state budget deficit situation. After a break, we'll have a brief update and status about some of the changes that we're working on with Benefits 24/7 and introduce our new CIO. We'll then move into a report about the appeals volume that has occurred this year. Right around this time is where we have a better sense as to the volume of appeals related to issues that came up during open enrollment. So we'd like to bring that to the board. We can't have a board meeting without a Medicare update. There's always things to talk about in the Medicare space. So we have a trifecta panel of Laura, Molly, and Luke that you're all familiar with. And then we will end the board meeting with a presentation by Dr. Schultz and Jenny Switzer about prior authorizations, the ins and outs 101 of prior authorization. I know this is a topic that some board members have reached out about and asked for and indicated that it would be coming this at the March meeting. Two final reminders. If you need the restrooms, you go down the hall. If you see elevators, look to your left. And if we have an emergency, like yesterday's fire drill, which was just a fire drill, we encourage purposefully walk across the street, we don't run, to the visitor lot over there that I'm pointing to. So with that, back to you, Chair Leclerc.
So today we will be voting on 3 sets of meeting minutes. July 11th, 2024, the meeting minutes from our special board meeting on August 5th, 2024, and the board retreat minutes from January 30th, 2025. Your meeting minutes are behind tab 3. At this point, so let's go ahead. We will be doing a vote on the July 11th meeting minutes. Are there any comments from the board?
We have information. I should know this after 6 years, but do I vote on minutes?
Don, your authority is to be able to make motions and seconds, but not vote, even on minutes.
Okay, I wasn't sure.
Thanks for that clarification.
Thank you.
So, okay, so do I have,
Elliot.
oh, I'm sorry.
It's okay. I probably should have pressed this button. Right? But anyway,
Oh, but press it so folks can hear you.
Oh.
Go ahead.
thank you. See, you already know. On page 2, I found a typo. I don't know if it matters. It's the second paragraph, and it's the second to the last sentence. I think it's why the program is being introduced.
Oh, I see. Program I being introduced. I see what you're talking about. Did you see it, Dave?
Yes.
Okay,
Yeah.
great. So we can make that amendment. All right. So, do I have a motion to approve the minutes as written with that
So moved.
amendment? So moved. Thank you. Is there a second? Second with John. It's been moved and seconded. So all in favor, say aye.
Thank you very much. Aye.
Aye.
Any opposed?
Yes,
All right. July 11th, 2024 minutes are approved as written.
4.
Oh, I should say as approved as amended. Thank you. So let's move on to August 5th. So for the August 5th board members, board meeting, any comments from the board?
Okay, thank you so much. I'll have to call you.
All right. So do I have a motion to approve the minutes as written?
So move.
See, well, you guys tied, so who do we give it to?
We'll give that one to Tom and then make Elliot the second. Does that work?
All right, we'll make Elliot second. Thank you. So do I have a motion to approve the minutes as written? There's a movement first, and so there's a second. Is there a second? All in favor, say aye.
Aye. Aye.
All right,
Aye.
thank you. Any opposed? All right, the August 5th minutes are approved as written. So now we go to the January 30th, 2025 meeting minutes. Any comments from the board? Right, do I have a motion to approve the minutes as written?
So moved.
Yeah, thank you. Do I have a second?
Second.
Thank you. So all in favor, say aye.
Aye.
Aye. Aye.
Any opposed? All right. So the January 30th, 2025 minutes are approved as. So I think our next item is retreat.
Yes.
So Dave will be taking us through follow-up for the January retreat.
Good morning again, everyone. I just have a couple of slides that are follow-up questions. Remember, try to integrate it into various presentations where possible, and if it doesn't fit anywhere, then I get to do cleanup at the beginning. So if we go to the next slide, you might remember, and Tanya will remind everyone about this as we go into the presentation later today, that Governor Inslee's proposed budget included closure of the UMP Plus plan at the end of this calendar year. We have a contract that goes through the end of 2026, but would close the plan a year early than what the contract currently supports. And so the question that came up last meeting, and we will go through this more as we talk about any type of plan closure, what would be the other choices for individuals who were in the UMP Plus plan? And so if we go to the next slide, the first part that we try to highlight, because it's usually the paramount question that people ask is, will I be able to see the same provider? And the situation with UMP Plus and the other UMP plans is that members are actually gaining access to a larger set of, the broader set of UMP the UMP provider network, because UMP Plus, there are incentives to stay within a smaller subset of the overall network portfolio. So in this instance, every provider that people are seeing today are already in the broader network. So that provider shuffle challenge that so many have whenever a plan closes, that really doesn't exist in this type of situation. The other piece is that UMP Plus members would be gaining access to the Centers of Excellence program. So that's the total hip and knee replacement, as well as the spinal fusion program. That is something that applies to the UMP Classic, UMP Select, and UMP CDHP plan, but it has never been embedded within the UMP Plus contracts. So if someone is getting a knee replacement and qualifies, and they go to the contracted facility, they end up having no cost share. So that is a benefit enhancement that they have, as well as access to the doctor on demand program. Elliot, I thought that you might have a question.
No, I was not.
Okay, great. But it's not all positive things. So just want to highlight a couple more pieces, just to give a more thorough comparison of the different plans. So on the next slide, I wanted to talk about the difference in deductibles and some of the cost shares. So UMP Plus today, that deductible starts at $125. I say starts at $125 because if you earn the wellness incentive, you can actually get down to a zero deductible plan. The other portfolio options in the portfolio, the next deductible level that's closest to $125 is $250 in UMP Classic. It's $750 in UMP Select, and then I can't remember if it's $1,600 or $1,650, but it's the minimum requirement of the IRS to qualify as a high deductible health plan in the UMP CDHP plan, but wanted to describe that deductible difference that people would experience by having to move to one of the other UMP plans. The other piece is that for deductibles, there is no separate drug deductible for UMP Plus, but the other UMP plans do have drug deductibles. In the CDHP plan, it's embedded, but the most comparable piece of the plan that by highlighting UMP Classic so much is drug deductible is $100 Classic. Another benefit difference between these two products is that in UMP Plus, there are no co-pays for primary care visits. That is one of the benefit enhancements and features of UMP Plus, but the other plans do have co-pays that individuals are subject to. Outside of this summary right here, all of the other cost shares are the same between UMP Plus and UMP Classic and the other and UMP Select. So all the other cost shares would be the same, similar in the other parts of the portfolio. So before I move on to UMP Plus versus the other UMP plan, which again, we'll have presentation later in the board season if the final budget includes closure of that plan. I'll talk about the provider network dispute that's going on publicly right now, but I want to see if there's other questions about UMP Plus versus the other portfolio. Elliot, you turn your mic off.
Is the reason that UMP Plus might be closed is cost?
There is a cost component. I'll actually gonna hold that question until Tanya comes up. She has a part of her slides that she'll definitely cover that.
Data, if there was anything available.
I want to see if you have a question because you have a hot mic.
Yes, can you hear me?
Yes, go ahead.
So it's fair to say that the people who are going to be affected by this, those that are members of Plus, are going to have about a minimum of $350 added to their expenditures. That's a minimum increase.
This would be paid.
That's the plus side of the equation. I'm sorry, plus UMP Plus. That is the increase side of the equation, but the premium for UMP Classic, for example, is lower than UMP Plus. So they actually would have a reduced premium. I can't remember the exact amount this year. It's somewhere in the $10 to $15 per month range. And that we had projected that the cost of UMP Plus relative to UMP Classic, that spread would continue where UMP Plus would have higher premiums relative to UMP Classic, and the growth of that would expand over time. So there is a premium reduction that's part of the calculation, but we can't say yet what 2026 premiums will be. But just don't forget about that part. There is a savings from the premium side.
And then given the, how many members are there in UMP Plus right now currently?
The
42,000 or so.
Okay. There are about 42,000 between the PEB and SEB programs and a little over 30,000 within just the PEB program, Tom.
So my only other question is, given the communications, the correspondence, there were a number of questions about communication and how things are effectively communicated. I'm wondering if UMP Plus goes away, what kind of communications are going to be sent to the people who are currently in it?
I'll do a little bit of a answer right now and know that we will include the communications campaign aspect when we bring a presentation later in the board season. We've had a variety of changes in UMP Plus over the year. There have been service area changes. We even had a county that switched from one of the networks to the other networks, and there are targeted communications that go directly to those specific enrollees that are impacted when something is happening with this plan. We do this anytime there is a service area change. We've had many over the years between the PEB and SEB programs. There are targeted letters that discuss and are sent to individuals to let them know what plans are available to them and give them access or point them to access where they can compare plans so that they can identify what they think is the most comparable plan. We will also then work at HCA to identify what would be the plan that those individuals be automatically enrolled in. That's called a mapping exercise. And so we identify what plan we think is most comparable from a premium and cost share standpoint. That way, if individuals don't engage, make an affirmative election, they can't be put into waive status. They have to be put into coverage under board policies. And so we identify and put them in a specific plan. And when we talk about a closure later in the year, that is again in the final state budget, we'll talk with the board and share with the board what we think that automatic enrollment plan would be. But there are targeted communications that go out, and I imagine that if this were a closure that is ultimately in the final state budget, that would also be a feature of the benefits fairs and part of the virtual benefits fair as well. And Tom, we'll definitely talk a little bit more about some of the communication pieces that we're hearing from members. A lot of it centered around IRMA and the change in Part D, and we'll talk about that some in the presentation later today with Laura, Luke, and Molly.
Thank you.
Kyla, I saw you had your hand up. Any more about UMP Plus at the moment before I talk about provider disruptions? All right. Just before this meeting, I sent the board a link. Didn't expect you to read it in time, but I wanted to make sure you had it. This is something that the agency published on Tuesday and did a refresh of it yesterday. But as we head into spring, we often have network disputes that come up over the past couple of years. We've had, I think the board might remember, there were 3 or 4 very prominent ones last year between the PEB and SEB programs. And there have been several over the past, since the pandemic, really, the closure of the plant, the end of the pandemic. And so this year's first provider dispute that has resulted in the legally required notices sent by the carriers under OIC rules involves Providence, Swedish, and PACMed. And so this is part of Regence's contracts, which are the backbone and are the provider network for all of the UMP plans. So about 55,000 members between PEB and SEB in the greater Puget Sound area. And so when I say that, I mean King, Pierce, Snohomish, Thurston, as well as Spokane County, which is obviously Puget Sound, but the greater Puget Sound area plus Spokane received letters. Many people started actually physically getting them the end of last week or the beginning of this week, informing them of this potential network disruption on April 1st. So the current contract for that network goes until the 31st. In-network services received between now and then are still considered in-network, and we provide information that if the termination actually came to fruition, what the cost shares would look like, because they would be considered out of network after April 1st, except for emergency services that are cared for in an emergency room. Those are always still covered at a network rate. So we start to provide that information. We've kind of gotten this down to a little bit of a science of the type of information that we put out and share. I do want to make sure that everyone's aware, the vast majority of time, although there is not a guarantee, these network disputes often resolve before an actual termination occurs. In the time that I've been director, there has been one such termination that actually went to termination, but the two parties 18 months before that termination were effective were very clear that they were going to be separating. And so it wasn't a 30-day exercise in that instance. There was a 1.5-year transition because those two parties were very clear that they were going to be breaking up in their network status. All of the other terminations that have resulted in mass notifications out that involve the PEB and SEP programs have ultimately resolved. Again, there's not a guarantee, and it's very stressful for members who haven't experienced this before to understand that it is likely that it will be resolved. And we're trying to convey that message without promising that there's a specific outcome. Again, at HCA, we do a lot of monitoring with the parties to understand if there's a breakdown in communication. We can't require a contract to sign, but we obviously have a lot of influence as one of the largest purchasers, including with Medicaid, and all providers are basically Medicaid providers too. But there's a bigger equation, but we can't mandate a contract sign. So we are in the process of doing that communication electronically, providing it out to various folks, including yourselves. I just wanted to raise that awareness because it is a current hot topic, of course. Any questions?
The process for this question, because I'm not exactly sure what I'm asking for yet. I know during the retreat, when we had representatives from Regents and Kaiser here, they kind of shared that they believed this was a tactic used by the providers to try and kind of leverage to get clients to kind of call in or kind of create that sense of urgency. I'm just trying to think about the impact on our members, and is there a way that we can have a conversation like and help that have that influence that you had mentioned, and or work to communicate at least with our members to help them better understand not to freak out? Because I remember the first time I got a letter, it was very concerning, and I was worried that I was going to have to go find a new primary care provider. So just trying to think about, like, is there something we can do?
There's a couple of pieces. Not that one e-communication is the be all end all, but we have updated our template to add a couple of features. In fact, we added this as a question to draw people's attention to it. What do I need to do if I receive the notice? And then the first thing we say is you do not need to take action right now. Services are covered through the end of the month. And then that hopefully slightly more reassuring message, which we've actually not included in our communication report, that asks people to check back on this exact link for updates and keep in mind that most of the time a new network agreement is ultimately reached without any network disruption occurring. We haven't said that as much publicly, but it is something that, because of the frequency at which this is happening, it is a true statement that the vast majority of times this is resolved. Now, it's, that one thing that we're working on doing, and I know Jean Bowie will be happy that I'm saying this, we're really trying to encourage members to sign up for e-communications, not so that we can flood them every week with something, but there are certain things that are time sensitive that if we were to write a letter and mail it, people wouldn't get it till next week, probably in most places. And when we're talking about a situation that is happening in like a 20-day time frame, that lag is just problematic. We only have about, I should say we're up to almost 30% of our population who voluntarily gives an email. We were in the low 20s for years. And so we're going to be doing some more concerted pushes so that when we have communications like this, that we can push something out directly to members whenever possible to try to help reassure them. Without that access, it's a little bit problematic to be able to get things directly in their hands. We do things like push out these types of communications to benefits administrators so that they can send things part of their mailings within an agency. And so that's why something like this is really key for us, because we can make more real-time updates on our own website, have a central page to send people to. And then there are different stakeholders. I know Kurt reached out and said, do you have your page yet? And we're pushing, and I pushed the link over to him yesterday, whenever it got published. So those are the types of things that we try to do. There is also a bill in the legislature. Can we just check on the microphone feedback? There is also a bill in the legislature about provider negotiations and these public notices. So there is a bill that we can talk about that is still alive and still working its way through the process that could be impacting this. And the last part of your question that I was going to say is, I think of it later. There was another piece I was gonna highlight, but I can't think of it. John?
The bill you're referring to, is that EOIC mandates this notice goes out a certain period of time before? Is it possible to push that back to a 90 or 180 day notice?
The bill in the legislature right now is really focused on what both sides between the insurance carriers and the providers can or can't say publicly. It doesn't really do much change to the actual notification timeline process as far as I can remember. But we'll have Kate go through some more of that bill, or more likely as the bill, next meeting, we'll go into more detail about the very few number of bills that actually look like they'll pass the legislature. I do remember the other point I was going to highlight, Michaela, is last at the retreat, we had a panel of the networks, and the theme that you highlighted was, is it a negotiation tactic for the providers? You can ask both sides and they will say the same thing about the other side. Both sides feel it's a tactic for the other side, and the role that our agency has tried to play, and in part some of the legislators asked questions that led to the bill that is in the legislature right now, was trying to remind people that the consumers are stuck in the middle of all of this. But I just did want to highlight that, yes, we had a carrier panel, if you will, but if we had had a provider panel, the same type of theme of the other side making a tactic, and the truth is always somewhere in between. Elliot?
I heard you mention that Kurt contacted you. It might be helpful to contact the public retirees and the retired teachers as well, because they can reach their members.
That is actually on my to-do list after the meeting, Elliot. I've responded to Kurt's, got it to the board, and I was like, after the meeting, I was thinking the same thing. We have a core group of stakeholders, benefits administrators, and labor partners, and getting to the various, I think we have 5 main stakeholder meetings, going through those and making sure that they have it as well. So absolutely we'll do that. Any other questions about the current network dispute? Not?
Got everything?
I think we're good.
Thank you. So next, we have a legislative update. So Kate Walker with our policy rules and compliance manager from the Employee and Benefits Division is going to bring back the latest news about bills and where they are with current legislation. So thank you, Kate.
Thank you, Chair. Good morning, board members. Kate Walker here to provide another legislative update for you all. Legislative session is moving along quickly. We just had another cutoff last night for the Chamber of Origin cutoff. So another good date. So I apologize that the slides are a little outdated just because of things having moved so quickly right now during session, that there's some revisions that I'll make orally to the presentation, just as a notification of last night of what made it through off the chamber floors. So we'll have a little bit of updates there, but we'll get started here. Next slide, please. Just real quickly, and this number is outdated as well because we continue to be working and moving forward. We're now up to about 190 bills that we've analyzed in our division, with a split pretty significant. We've had a lot more leave legislation this year that we've been tracking, but not as much, not nearly as much high priority for as many bills as we've been analyzing. So team's been doing really well. I want to make sure I give a shout out to the 35 analysts in ERB that work diligently and around the clock sometimes to get legislation analyzed and out the door, so we can make sure we're informing the legislature of impacts that we know for things. I also want to give a shout out to the finance team for doing a great job with all the fiscal notes that they've been doing, Tanya and her team. You can see here we've had quite a substantial number of fiscal notes this year. Even with the budget crisis, there's been a lot of interest in making sure that we're on top of what's happening. Things have a financial impact with the policy decisions that are being put forward up on the Hill. Next slide, please. These are the high priority bills that we're tracking, and if you're a number hound like Dave, you'll notice that the high priority number of bills listed here does not match the number of bills, the high priority bills listed on the other slide, and that's because these are the individual bill numbers that are going through. But the previous slide is actually a bill analysis. So every time a bill gets another version put forward, we have to do an analysis on that to see what has changed and update and revise. This just looks at the bill numbers themselves to see what bills are moving through. And even this is a little bit outdated now because the number of bills that have moved through to the opposite chamber, either policy or fiscal, is quite a bit more than it was when this slide was put together. Next slide, please. So we'll take a look at our agency request legislation bills. 1123 actually did not make it off the before last night, but Senate Bill 5083 did move forward and is now in the House for consideration. This is the HCA Policy Division's affordability bill, or short titled Ensuring Access to Primary Care, Behavioral Health, and Affordable Hospital Services. It does look like that's got some legs and it's moving, given that the House bill moved pretty substantially, made it to the floor, and the Senate bill has moved off the floor and is now over in the House. So I think there's a good chance we'll see that one go the distance. And that has a lot of implications, I think, for kind of broader network contracting and other things that we see this make across the finish line. We'll be sure to provide a lot more updates on the impact of the bill to our PEB and SEB program plans. We also have our PEB Board Authority bill that we drafted. This is from our division. This is the legislation that would grant you all board members the virtually the same benefit offering authority that currently exists for the SEB program. For optional benefits, there's a slate of optional benefits that the SEB board was granted authority for, initially to try and avoid some of the duplication of offering of benefits between the school district and the SEB program. Such things like the income replacement plans like cancer insurance or pregnancy insurance or hospital confinement insurance that are meant to replace your income but not actually cover the treatment services. Travel insurance, legal assistance, the one that I know a lot of people are interested in is pet insurance. So this would grant the board the authority to provide those benefits if there's funding available to have the program kind of pick up those bills and study them and do a procurement and have a manager for it. But that the benefits themselves would have to be voluntary, 100% employee paid benefits if they were to be offered based on the way the legislation is written. We'll continue to track that, and that's that bill is still moving as well. So I don't think it's had a nay vote so far. So I think it's looking like it'll probably move through and grant you all that authority to consider some optional expanded number of benefits in the future.
One quick thing, Kate, you did say employees on 5478, but after stakeholder retirees, the bill actually did get dropped and includes retirees' ability to also pay for those benefits at 100%. So just wanted to add that in.
Next slide, please. And right off the bat, so we have House Bill 1069, and this is something I need to clarify from the last meeting from the retreat. As I understand the legislation a little bit more, this is allowing for collective bargaining for contributions for certain supplemental retiree benefits. This allows for active employees to negotiate for benefits that would be made available, or contributions that would be made available to retirees. So there was a little bit of confusion on my part about who would be actually doing the bargaining for benefits for the retirees. And so upon looking at, just to clarify, this was a question that Elliot brought up, that making sure that the active bargaining, so active associations who are bargaining are able to bargain for benefits that and contributions that would be made available to retirees. So that's what that legislation is doing. While the Senate bill hasn't moved, the House bill is currently still moving and still active after last night. House Bill 1076 did not make it through last night. We've made some revisions to the health technology assessment program that's housed here at the Health Care Authority. It did not move forward, but we'll continue to track it and see what happens to it possibly next year. The House Bills 1330 and 5086, the PEB-SEB consolidation legislation, that had neither of those bills moved forward. They did not make it out of the fiscal committee, so that is not moving forward as far as we're aware for the session. But we'll continue to track that and see what happens for next year. Yes, ma'am.
Okay, you want me to wait till the end?
By all means.
For 1330 and 5086, did it have a fiscal note associated with it?
It did, yes.
And was there a cost or a savings?
There was a cost associated with it. The details on it were largely based on the IT needs for it, and then there were some other aspects of the accounts that we switched over that had some implications, but I'm not sure the full fiscal impact of that. But Dave might want to speak more to that.
And if we go further, Tanya, feel free to join me on this. It's a complicated fiscal note because of the implications for the EMC in both programs. And so the fiscal note actually describes a range of potential outcomes, some of which have greater swings for what the state pays in both programs versus what the employee pays. It was generally the two scenarios were on the range of plus or minus $12 to $15 million, which, as Tanya will highlight later, the programs by the annual cost of the two programs is in the $5.5 billion range. So yes, $12 million is a swing of plus or minus 12 million is $12 million is a lot of money. It's also a small swing, and so it was a relatively small swing in the grantee, but it was hard to identify a specific outcome, so we did do kind of a high and low range. We thought the implication would be. There was a small administrative piece, I think it was the $2 to $3 or maybe $4 million across the biennium for one time, mostly for IT system pieces.
Then this is the bill that Dave was referring to a little bit about those provider negotiations and notices being sent to members. Senate Bill 5579 is still moving through, active as of last night, made it through the Senate and over to the House. And just for a little bit more information on it, it doesn't change up too much of the timing for notifications, but what it does do is requires that before such notifications can go out, specifically those to the members, that they have to satisfy a quote, a legal obligation, and that there must be, or there's the expiration or termination has already been disclosed publicly because of a legal obligation. So it's putting some parameters around how those notifications go out. I imagine largely in response to the way that the requirement for notification has kind of played out in the last few years. And so I'm glad to see the legislature taking some action on that, and 5579 is actively moving through the process this year. Next slide, please. House Bill 1124 and 5112. Actually, both of these have now failed to move forward. This would have allowed psychologists to have, the last iterations would have allowed the psychologists who don't otherwise have prescribing authority to have a very limited scope of prescribing authority to provide for refills for medication for patients that were, for behavioral health medication for patients who had already had a prescription made by a psychiatrist or a primary care provider. That legislation is not moving forward this year. However, House Bill 1114, Washington's participation in the Respiratory Care Compact, is moving forward, as is the ARNP and physician-assisted reimbursement increase, and that is moving forward as well. The expanded pharmacist scope of practice, that is not moving forward. That would have allowed pharmacists to have the ability to provide some refills on medication that been provided by a primary care provider as well. Neither of those are moving forward this session.
Do you know why the 5112, like what the pushback was on that?
No. I mean, I won't conjecture on it all. I mean, I think the notes that have been in there speak to it, but the ultimate reason for it, I wouldn't guess on that. I mean, I could, but I won't.
But you won't.
I wanted to see that. I think it's an interesting idea. I think it's all right. Moving on. Health plan coverage. Thank you. The biomarker testing bill, which we've seen come up for the last several years, and failed to move forward. House Bill 1090 and Senate Bill 5498, contraceptive coverage. This will allow for initial prescription for contraceptive coverage to be made for up to 1 year, as opposed to just refills, allowing for a little bit better access to contraceptive coverage for durations. But the fertility-related services and the cost-sharing bill for prenatal and postnatal care, neither of those made it out of the fiscal committee a couple of weeks ago. But I imagine we'll continue to see that. It is obviously a very hot topic up on the Hill, and we'll continue to see that in the years to follow. We'll be tracking. I imagine on the fertility-related services, without having to feel too scary about conjecture about it, is that the cost of that legislation was prohibitive. House Bill 1669 and 5629 coverage, expanded coverage for prosthetic limbs and custom orthotic braces, increasing the rate at which those devices can be refilled. Is the wrong word, I guess, because it's not like you're refilling a prosthetic or orthotic, but having it redone or kind of adjusted or having improvements made to it, having the availability for that to be increased is moving forward this year. Lastly, on the pharmacy side, House Bill 1186 and Senate Bill 1519, which ended up being essentially companion bills, even though when 1519 was introduced, it had a different title and some different language. It ended up having a revised version that became identical to House Bill 1186. House Bill 1186, this is allowing for some expanded amount of medication that can be prescribed out of hospitals and healthcare entities. I think predominantly looking at emergency room services and expanding the availability of certain medications, dosing amounts to be made at a higher quantity. House Bill 1186 is moving, although the Senate bill did not make it out of the chamber yesterday. And then last, House Bill 1971, increasing access to hormone therapy. I had a mistake here before in some previous iterations of this where I refer to it as hormone replacement therapy. It's actually broader than just hormone replacement therapy. It's really the entirety of hormone therapy that's available that allows for medication distribution of up to 1 year supply of hormone replacement therapy. Hormone therapy to be distributed from providers. And with that, that's the end of my presentation that I tried to fly through. So if there's any questions, I'm happy to take them.
One thing I'll add for the board or for the public who may not live and breathe the legislative process as much as state agencies do, is this whole concept of companion bills. And when Kate said this one didn't make it out of the House, but it did make it out of the Senate, you can't necessarily read into that too much, but you also can't ignore it too much. Sometimes it's just the legislature saying, okay, well, there's only so many hours on the floor that they're going to be voted on. And sometimes the chamber coordinate to say the vehicle for this conversation will be the House version going forward. It's actually quite unusual for companion bills to both pass, but there is, the prosthetic orthotics one is an example where both of those passed in different forms and go to the opposite chambers. Sometimes that it not passing in a chamber is indicative of challenges in that chamber, and other times it's just simply coordination of the chambers to manage their time. So just my way of saying, don't read into it too much, but also don't ignore it.
Well, the one last bill I want, real quick, one last bill I did want to note that I just thought was interesting, and it got actually introduced after several of the cutoffs, which I think was really unusual, but it does tie into some of the other work that we've talked about here, which is data collection. Senate Bill 5874 is titled Encouraging Agencies Demographic Data Collection. And so I just wanted to note that as we've talked about here before, some of the efforts that we're undertaking at expanding our data collection efforts on our membership. Missy Yates has been here, I think, to talk before about the race, ethnicity, language, and the gender orientation, sexual orientation, gender identity information that we're working on building the capacity within our system to collect. It's interesting to see the legislature is also kind of catching on a little bit and saying they wanted to see expanded demographic collection from all agencies. It's a little smaller than the set we're hoping to do with our population eventually, but it is of note to put out there that some piece of legislation did get put forward well after the cutoffs, showing some interest in there from Senator Hasselkamp.
A few comments then, just on that, if we can maybe connect offline. I know with our business resource groups and data employment, we've gotten some feedback lately around kind of concern about sharing more expensive demographic information and wanting that in the public or not wanting that in a public record, just kind of concern around how that data might be pulled and used in not so great ways. So happy to connect with you all, Gwen. And then I think just more for the record, because I completely understand the budget process and the kind of the situation that we're in the legislative process, and also just kind of doing the call back to the provider information that we got around kind of the impact around fertility related services and prenatal and postnatal care. So just wanting to share, like, if there's anything that we can do to help in future years help the legislature understand how much that would be meaningful for our members. Just wanting to put that on the record.
I'll also highlight that many board members may remember last season we had someone speak on public comment very eloquently about the very challenging circumstances. And I actually reached out to her and made sure she was aware of the committee process. She did testify before the committees about the bill. Not the outcome that many people want. That is where that bill landed, so to speak. But I think that's an excellent point. Michael, I did want to kind of bookend a little bit about Erica's public comment to the board here, and then also say there is another factor that we don't know the answer to it yet, but there's a lot of discussion at the federal level about things like IVF, and we all don't know whether there will be things that expand coverage on the federal level, and if that will or won't apply to what plans. But there's at least that federal conversation that's going on in this space that has at least permutations in that choose your own adventure book that lead to some sort of coverage. So we're definitely monitoring that situation as more of that conversation unfolds at the federal level.
Anything more for Kate?
Kind of a third rail question.
Okay.
Has any proposal come before the legislature for gender reassignment surgery and funding it through state health plans?
There are no active bills or pieces on that legislation at the time, as far as I'm aware of. So I don't believe the answer, I think, is just no.
There were some things introduced and failed to make it to a committee.
One other piece that I wanted to highlight on Michaela's first point about data, and concerns about data being collected, kind of a preview of maybe 2 presentations down, but we're focused on stabilization of our systems. And while Kate's correct that we are, in our work plan, we had been building and we will continue to build that capacity, it's also not front and center as the priority for our IT systems either at this time. So to the extent, we were on a path to hopefully be able to begin that type of collection later this year, that seems extraordinarily unlikely as we, fully focus on stabilization and debugging of the 2 systems. So to the extent that provides a little bit of reassurance in the short time, it also allows that conversation to unfold more like you were bringing up, Kyla. So I did want to lay that out too.
Great, anything more? Thank you. So right now, we have Tanya come up and join David, and we'll be talking about a presentation on the agency's ongoing budget reduction scenario work in order to help the governor's office and legislature address the state budget deficit. So the materials behind tab 6, so just an update from where we are with the budget conversations that are going on with the legislature and with the governor's office.
All right, thanks, Chair Lindeblad and members of the board. I am back to talk to you not about a specific Senate or House proposed budget yet, but we are going to kind of walk through what has been happening in terms of the budget and some of the various directives that we've had and kind of where we are to date. You'll all probably remember back to the retreat when Robin from OFM came and discussed the revenue forecast and the status kind of the budget at the time, which was the state was projecting about a $12 billion deficit over the next 4 fiscal years, to the next 2 biennia. And as Governor Ferguson mentioned in his latest press release, he mentioned upwards of $15 billion deficit. So we're talking, there's some different numbers thrown out there, but it is a very significant deficit for our state. And we have next Tuesday on March 18th is the next expected revenue forecast. So hopefully we'll have some updates there to whether the position is getting, better or worse. But walking through some of what has happened since then. So on December 2nd, Governor Inslee directed all of the agencies under his direction and control to freeze non-essential hiring, spending, things including not hiring positions that weren't related to public safety or other non-discretionary activities, putting a freeze on non-essential service contracts and goods and services purchases, as well as non-essential travel. So that was on December 2nd. The agency kind of took that and just put all of that into motion right away.
And Tanya, I'd like to highlight for the board, every agency implements a little bit differently these types of directives. And our agency in particular, very shortly after December 2nd, actually pulled down all of our active recruitments and really scrubbed and looked at everything that was potentially pending. Not every agency did it that way, but this agency pulled everything down and we went back, kind of like refroze everything and looked and said, there are some positions that probably make sense to go forward with, but not everything that was published or had been pending at that time. Our agency has generally focused on things that are outward facing customer service. So that might be people who are on Medicaid in the Medicaid call centers, answering questions directly for Medicaid clients. That includes PEB customer service, frontline phones for retirees. It includes the outreach and training staff that are the direct communications with the benefits administrators and HR departments throughout the state, both agencies, higher ed, and school districts. And it has also included, at least for the PEB and SEP programs, several key IT positions. Again, we've talked a lot about our IT systems and the criticality of catching up and righting the ship on that. And so we had a couple of IT positions, but we as an agency have taken a very deliberate and purposeful effort to try to maintain as much vacancy as possible, knowing that as Tanya goes through next steps, there is likely some, the footprint of HCA staff will ultimately get smaller in some way, shape, or form, and we hope to leverage vacancies as the primary way to ultimately comply with and meet those expectations and try to minimize the actual impact of individual layoffs as much as possible. So just wanted to highlight what we did in response. We had a couple, I think 100 or somewhere over 100 positions that immediately got pulled off and we reevaluated everything. So just wanted to highlight how our agency.
Yeah, so we did that early December. So then on the next slide with kind of what happened next. So on January 24th, OFM directed certain state agencies to identify and submit operating budget reduction proposals. There were certain agencies that were exempt from this process, including agencies that served K-12, community and technical colleges, Washington State Patrol, the Department of Corrections. There were certain agencies that were exempt from this process. And we were asked to submit budget reduction proposals based on Governor Ferguson's priorities, which if you remember, Robin described some of those, which were around public safety, housing, as well as his commitment to funding the collective bargaining agreement. As part of your appendix is the full detail of Governor Ferguson's priorities. So if you have any interest, you can flip back there and read through all of those later. So as part of this budget reduction exercise, we were asked to come up with a 6% reduction. And some of the items that we were to consider was consolidating of management positions, pausing all possible legislative reports, and making reductions to certain contracts, restricting further equipment purchases, further restricting travel, and evaluating programs that were either partially or fully implemented since 2020. So some of those newer programs. Now we're going to walk through kind of how this impacted the PEB and SEB program specifically. So OFM set specific budget reduction targets based on individual agencies' programs, specific spending. So we're going to get into the weeds a little bit about how the PEB and SEB programs are funded. And I am going to talk about both programs here today because there are some differences and really the approach was the same for both programs. So we're really going to talk about this as a whole. So the PEB and SEB programs are not directly funded by general fund state. The PEB and SEB programs have really two sources of revenue that come into the programs. That is the employer contribution, which we talk about as called the funding rate. So that's the employer contribution for healthcare for employees. And then we have premiums paid for either by employees or retirees. Those are our main revenue sources into the program. We do not get a direct general fund appropriation in. However, our state agencies, our higher education institutions, and our districts are all mixed with different types of fund sources. So on the PEB side, about half of the funding that comes into the program is general fund state. And on the SEB side, it's about 82% is general fund state. So while we don't get a direct appropriation from the general fund, our funding is a good percentage of general fund into our programs. So a 6% reduction target for PEB and SEB was directed for our agency's administrative account only. So that's the account that pays for things like our staffing here, our building lease, some of our phone costs, travel costs, printing costs, things really to administer the PEB and SEB programs, but not the benefits themselves. And even though we only were directed to do that specific 6% target on our admin cuts, we were asked to identify further savings options or scenarios related to all of our accounts. And as we get through the next couple of slides, you'll see why that's really important.
One thing I want to highlight, and this question has come up in the last 2 weeks, is to be clear that the request was a 6% cut on the SEB account and a 6% cut on the PEB account, and that's separate from the agency's general fund 6% account. Some people have said, oh, the agency has a 6% reduction target. What percent of that 6% is SEB? And that's not the right question, actually. They are separate colors of money is the way we say it here. So it's, they are separate swim lanes, and we had 6% targets for each of those 3 swim lanes. It's not a combined target for all 3 of them. So wanted to make sure that was clear too.
So on this slide here, it's getting into a little bit more of like the accounting stream that we don't usually talk about with the board, but I think it's important context for this type of conversation. So as we're looking at this slide, you'll see a green arrow pointing into that big orange square in the middle, and that's called revenue in. Like I mentioned, we have 2 major revenue sources that fund our program, and that is our state funding rate from the employer contribution, as well as premiums. So our retiree premiums and our employee premiums come into that big orange box in the middle. So for PEB, it's called account 721. This is not appropriated by the legislature, and it houses really the full source of our revenue. And then directly out of that account, where it says expenditures out in the red box, we directly pay all of our self-insured claims. So our Regents claims for the Uniform Medical Plan, our MODA claims for our pharmacy benefit, our uniform dental plan claims all come directly out of that, as well as our carrier premiums for our fully insured products. So Kaiser, Premera, United Healthcare, all of our premiums come out of that account also. But one thing that's a little unique here is that in addition, we self-fund our own admin accounts from that account. So out of 721, that big orange box in the middle, we transfer cash every month to those accounts below to fund our administrative costs. So we transfer money on the far left, it's called 730, and you'll see it says IB&P reserves. That is our incurred but not paid reserves. We keep a reserve outside of the main account for claims that we know have been incurred. So the claims have happened, but we haven't paid the bill yet. So we know there's some outstanding bills we have related to claims that have been incurred. So we keep those reserves in a separate pot of money. The next two boxes are our self-insured TPA, so our third-party administrator accounts. We have one for the uniform dental plan. For PEB, it's called account 438. And then we have one for the uniform medical plan, which we use to pay Regents and MODA out of, and that is account 439. So that is where we pay the TPA fees. Next, on the far right is the box we're really talking about for the 6% reduction target. For PEB, that is the account 418, and that's our agency administrative budget. So it's largely staffing, travel, things like that. But the point really of this slide is just to emphasize we self-fund our own admin from our big main bucket. It is not a separate funding source from the legislature. We have really one funding source that then we pay to ourselves to fund our other accounts.
And Tanya, the only appropriated account on that page is
the bottom right account. So the legislature does tell us an appropriated amount, how much we can spend out of it, but it still comes from our own funding source up above.
Yeah, I just wanted to make sure the board, Rick, the legislature sets the cap on the drawdown authority, and then we self-manage that cap.
I don't need a ton of detail on this because I don't think I would understand it even if you never provided it. But on the agency admin account, since that's the one the 6% reduction is being directed from, is that like, does it grow with the number? Like if a state government grows and the contributions grow, is it like a percentage based, or is it kind of you just divide it amongst and that number stays kind of the same every year?
The actual budget for 418 and 492, is that what you're asking?
Yeah, like I'm thinking about like agency admin, it's normally like, oh, 30% of is like your overhead that then gets, so as your FTE count increases, your admin amount increases, but then like, I know that our personal services fee is we just kind of divide it amongst the number.
Yeah, so our 418 budget has been largely stable with the exception, we do grow FTEs as you might remember over the last few years, I've come back and said we had a decision package funding for additional customer service staff. And we've been able to hire more staffing in portfolio management. So it grows as that happens, but it doesn't necessarily grow as our maybe caseload grows. So as enrollment grows, it's not a one for one. Yeah. We have to specifically ask for increased funding out of our budget for 418, and then it has to be approved by the legislature.
And Michaela, even for the UDP and UMP accounts, the primary cost of those accounts is the agreed admin rate times the number of subscribers or members. Even as that subscriber or member growth happens, we put in an annual decision package to true up and adjust to get the authority, additional authority. And so Tanya often says, she'll say, this is the DP that I always bring back and describe. It's the one to true up the enrollment changes that have happened in those accounts. So we do have, there's no automatic triggers even in those accounts. We go back every time and talk about the true up that's needed because of enrollment switching.
But as each of these accounts on the bottom increases, our total funding rate request increases all of them. So it takes about $1.7 million in expenditures from those bottom accounts to increase that funding rate by $1, if that helps. On the next slide here, we'll just Harry.
Yeah, kind of hard to hold the questions till the end.
Oh, feel free to interrupt, no worries.
So that agency admin, is it fair to say that any of those expenditures are coming out of the state funding rate?
Yes, and that's one of the points of this slide is because it's not a direct general fund appropriation, it's funded from our own funding rate revenue. As any of these accounts on the bottom are cut, the funding rate would naturally go down as a result of that cut.
Right, and just to confirm, that component that's revenue in, which is premiums. None of that agency admin is coming out of the premiums.
There is an agency admin component that is built into the total rates. So if there was a significant enough cut in our admin, it would be kind of rippled through premium development and then the retiree or employee contributions, yes. So a portion of admin is rolled through the total rates, so yes. All kind of connected. The next slide is really just to show the total budget and really kind of emphasize here, when you look at this slide and you just look right at that bottom line, you'll see $12.7 billion. This is the total spend over the biennium for the PEB and SEB programs. That is not small. That itself is equivalent to the total state deficit right now. We are a huge portion of the PEB, of the total state agency or the total state budget. So really what I wanted to emphasize here is that you did hear me speak to, we were asked to formally submit reductions for 6% for the agency admin, which is the two lines at the top, one for PEB and one for SEB. We were still asked to come up with options for all of the accounts underneath to help contribute towards the overall state deficit. And because that is such a large number, we can have an impact on the deficit with some of the options that we can propose.
And just to put another finer point on it, the annual state budget roughly right now before all of the next budgets come out is around $70 billion. So biannualize that to $140 billion and the PEB and SEB programs are 12.7. These programs are like 9% of the state budget. So when we are asked to look at funds, there are only so many levers that can be described, and several of them are levers that historically have always been described in these scenarios, and we'll talk about that more as we go through the presentation. But that's why the agency was asked to look at things beyond admin without a specific target cut. And then I will cover a couple of things about how the agency went about its budget reduction submissions. So this is going back to the Governor Ferguson directive at the end of January that Tanya highlighted a few slides back. The agency submitted a variety of scenarios. They're not formal proposals or recommendations per se. It's important to remember that the legislature and the governor's office are the decision-making process. They can consider topics that are not even on the list that come from agencies as well. So it doesn't even represent necessarily the high water mark. But our agency worked on, and I believe the submissions were due February 6th. We looked holistically. We were looking at Medicaid and PEB and SEB. They're different swim lanes, but we also think about the implications across all the populations that we serve. And we had an ultimate goal to try to preserve healthcare services for all Washington residents to the extent possible. And so a couple of things that we were thinking about those impacts, not only on the members we serve, but also our staff, looking at preserving essential programs, trying to remain flexible and prioritizing basic services, and staying true to our agency's overall value and missions. So we're going to walk through the different options that were included, but we will continue working with the governor's office and the legislature on various scenarios that are of interest for the next two bienniums. So we do a lot of technical support on financial modeling, as well as technical support of legislation to support whatever questions are coming our way from either the chief executive or from the legislative part of government. On the next page, just getting a little bit into kind of macro points about the PEB and SEB options. Several of them would require changes to state law. You know, the legislature is in town. We talk about, you know, it can be a gargantuan process to get a bill through the legislature, but also when it comes to budget things, bills can move really quickly at the same time. We saw, you know, we won't even go into examples, but they're in town and they can change state law, and then that can change what's required in these programs or in other programs. A variety of options relate to or could be impacted or implicated by the collective bargaining agreement. I'm going to kind of skip down to the end of the slide to talk a little bit about this, but the timing of that is so important. When we talk through these options, if people look at the option sheet that was published on OFM's website for the agency, there are a lot of options within PEB and SEB that are described as the earliest anticipation date would be January of 2028. Yes, if you look at your calendars, it's 2025 right now. But the way that works out and plays is Governor Ferguson has said multiple times there's a commitment to funding the bargaining agreements reached in summer of 2024, which impact fiscal years 25 through 27, which is really plan years 26 and 27 for this program. So the next time collective bargaining naturally happens is summer 26. That doesn't impact until plan years 28 and 29. Those are at least within the 4-year outlook frame. And that's why these are options that kind of get discussed and their implications. But we as an agency made an assumption that if they were to be selected, the earliest implementation would be January of 2028, because that's the way to thread together the commitment that the governor has already made about the existing tentative agreements that are subject to review right now and the natural collective bargaining process. We also traditionally have always aligned things, almost always, I guess you can never say anything with an absolute, with the beginning of a plan year. So there's often a January 1st implementation date for anything. Going back up into the slide, there are always a couple of options that might be unilateral decisions that this board could make. An example of that is back in 2021, the board here authorized UMP Select as an option. That was inserting another plan in the portfolio as another piece. And there are different cost share structures. So that rippled through the rates if there is enrollment that switched over to that plan. So that's an example of something that the board can do. I think the main point here, though, is to remember that, again, many of the things could impact collective bargaining. There are very few options that can immediately impact the state budget. They're more generally geared towards the outlook years, but that is a big part of this budget deficit situation that everyone is trying to address. There are a couple of options. Closing of UMP Plus, closing a plan is something that actually fits within all of the guardrails and could be done earlier. Moving reserves around is something else that's immediate, and we'll talk about this one. The Medicare explicit subsidy is something that can change every year and isn't subject to collective bargaining. So that is one that has a potential earlier implication, a timing implication. I do also want to highlight one bigger thing. When we talk about that gold bucket, the large Fund 721 bucket, there are really only a few ways to influence that multi-billion-dollar pot of money. I really kind of think of it 3 general ways. You can keep the benefits levels the same, but adjust the cost structure between employees and employers. You can keep the cost structure the same, but that, because things cost more over time, require potentially reducing benefits. And then the other part of the equation that doesn't involve benefit, those 2 pieces, is the potential for reducing the payments that go out into the system, that red arrow. And an example of that is the agency request legislation that Kate highlighted, Senate Bill 5083. That bill, just to go into a little bit more detail, has provider reimbursement caps on it for the largest hospital systems in the state. And so that's capping the growth of and cost and avoiding some of that growth that could happen in outlying years. So that's another example. Those are really the primary ways for this program to be influenced. And with that, we'll go and talk about some of the topics that are on that sheet.
And I'm gonna spill the beans as we go through this and tell you what's already included in Governor Ferguson's proposal before we get to our last slide. So I'll kind of give you a little spoiler as we go along. Yeah. All right. So these are kind of broken up into different categories. So the first one really is the administrative cut that we've talked about. This is that 6% reduction to our admin. So things that were included that we were able to identify were FTE staffing reductions. Again, remember the agency paused hiring back in December. So there are some vacancies that are available. There were some contracts that we had some variants that we could free up, both one time and ongoing. One example would be some of our actuarial variants from one-time things that is no longer needed. And then goods and services and travel, we identified some areas we can reduce there. So that one was included. The next one is related to our third-party administrators, so the TPAs, and this is a PEB only line item. There is no SEB impact here. What this reflects is acknowledging that there will be on the state employee side a reduction in workforce as directed by Governor Ferguson to look at management efficiencies. We recognize that there will be some downward pressure on state employees. This was not a directive of the SEP program yet, but we did acknowledge that that means there will possibly be a decrease in our self-insured enrollment in the future, meaning our third-party administrator fee obligation would possibly go down. There was no specific call out for booking any savings by Governor Ferguson for this line item.
Real quick, I just want to highlight, you said something that made me think I didn't say this earlier. It's a good reminder that the governor's office, what the governor's office kind of jurisdiction is. State agencies squarely under the governor's administrative directive. Higher education, not under the governor's administration. Administration of K-12 local school districts, not directly under the governor's authority. So often executive orders, including these types of freeze orders and reduction exercises, will apply to state agencies, and then there will be an appeal and plea to the other parts of government. The independently elected official offices, like the insurance commissioner's office, isn't subject to these agencies. It's thought of as a state agency, but it is an independently elected office. So there'll be an appeal for the other independently elected officials to do similar exercises in their respective agencies, as well as a call to higher education to implement similar pieces. So, that's why in the TPA account, we could only make this sort of swag adjustment for state agency reduction, of course, because that is the part where there have been directives and targets that have been outlined to try to hit. So just wanted to put a finer point on why we wouldn't make a set type of similar adjustment or swag at what the impact would be.
As we get down to the next category, benefits, like Dave described when he was talking about the three levers, there was one item that was identified under that benefits category, and that was the elimination of the wellness program. That means both the elimination of the WebMD portal, as well as the incentive that employees can earn by doing certain wellness activities. And that was identified for both the PEB and the SEP program. This was not included in Governor Ferguson's most recent budget. So the only one, just a typo on that slide, was the administrative 6% reduction. Yes, John.
The cut wasn't included?
That
or-
was the only one, the 6%. Yeah. And on the next slide, we're going to talk more about some of those different funding sources, talking about kind of premiums and different revenue sources. So under this state funding category, the first item that was included was a reduction to our premium stabilization reserves. This is our PSR reserve. This is different than the reserve I talked about on that little flow chart in the bottom left, our IBP. Our premium stabilization reserves are really that. They're there to stabilize premiums. Currently, we keep 7% of annual self-insured medical claims and 4% of self-insured dental claims in reserves. When we talk about a length of time, it's really less than a week's worth of reserves on hand, but those are kept in our fund balance. The last time we've really had to dip into these was back during the COVID times when things were, a little unpredictable. And that's really what these are meant for. The Governor Ferguson proposal did include a reduction of our PSR reserves. So what that means is a recommendation to keep less dollars in our premium stabilization reserves, freeing up those additional dollars, which would put downward pressure on the funding rate. I really want to emphasize here that the legislature has the sole discretion to fund the funding rate at whatever risk and whatever level they want to take for the program. So at any budget cycle, good times or bad, they can choose where they want that funding rate level to be, ultimately taking the risk for the PEB and the SEP programs. This is just one lever that they pulled to be able to bring down that funding rate. There are additional levers within the model that they can choose to explicitly bring down the rate. They can also choose just to underfund the program and fund it at a lower rate and hope for the best. Catch up with it in another program or in another year. And that's what we see every year when I'm back here talking about the funding rate changes. So this one was included, a reduction from 7% to 5%. The next one up is something that is always on the list, which is changing the split for the employer medical contribution. This again is the amount that the employer contributes towards employees' medical benefits. It's currently set in the active collective bargaining agreement as well as the tentative agreement for the upcoming biennium at 85%. There were options on the list included anywhere from the 85-15 down to 80-20. Nothing for this was included in Governor Ferguson's most recent version of the budget. Something else that was considered is applying a premium to employee dental. Employee dental is 100% employer paid, and there was an option to look at adding an employee split to that. This again was not picked up.
Real quick on that one, because this is probably one of the most frequent questions I've been asked in the last 2 weeks, is, well, if there was an employee premium on dental, would people be able to waive that benefit? Because right now it's a mandatory benefit because it is employer paid. We would certainly be talking with the board about whether and how to account for some sort of waiver scenario. However, we'd have to also talk at that time that would likely drive rates up. Because most people who waive benefits are non-utilizers, and the way that we spread the risk and the numbers across the model, you would have a smaller denominator, which means that the actual dollar amount, we still have to collect the same amount of money, would go up. So there are implications, but one of the most frequent questions I've had is, would we be allowed to waive benefits on this? And the answer is, we talk about it. There'd be a compelling case to look at that cost structure. So just wanted to acknowledge in that type of scenario, so we'd certainly be talking through that.
The last one under the state funding list was a new item, which was applying a $25 per account dependent surcharge. So accounts that had more than 2 children. When you look at the dependent kind of load for the various numbers of dependents, children dependents specifically, there is a clear drop off after 2. So the majority of the accounts have 2 or less dependents, and this would be applying a per account, not per child, dependent surcharge. It would be operationalized similar to how we do a tobacco or spousal surcharge, and just be added onto that monthly premium. This was not included either. The last one on the list, like Dave mentioned, is something that we include on most of these exercises, which is just looking at the Medicare explicit subsidy. I think this board is largely aware the Medicare explicit subsidy is the state's contribution towards our Medicare retirees premiums. It's currently set at $183 or 50% of the premium, whichever is lesser. And the legislature could choose to move either of those levers, change the cap or change the percentage. And this was not included in Governor Ferguson's. It was left at $183.50. So next slide, just to really tie a bow on this part. On February 27th, Governor Ferguson did announce recommendations to the legislature. There was a press release associated with it. And of the things we just walked through, the only 2 that were included was the 6% admin reduction for the PEB and SEB programs, just the agency admin portion, as well as reducing our premium stabilization reserves that we hold in our fund balance. And none of the other scenarios were included. I do want to caveat, the legislature has these lists. The lists are public. It does not mean that this will be what is included in the final budget. It doesn't mean that there won't be more or less included in the final budget, but as we have those, we'll bring that back to the board. And I want to note that all of this was on top of Governor Inslee's proposed budget, which we talked through at the retreat. As a reminder, the couple of things that were included in Governor Inslee's budget was the closure of the UMP Plus plan, which we talked about, Dave mentioned at the beginning of the board meeting, effective at the end of the current plan year. And then also the contribution to the state general fund of the employer paid long-term disability claims fluctuation reserve balance that's above what is required in that account. So our employee paid or an employer paid long-term disability reserves are kept in 2 separate accounts. This is just the employee paid portion of the reserves that are above what we are required to keep. We will withdraw that and submit that directly to the general fund. Next slide is just really kind of the next steps here. I alluded to, this isn't the final budget. We're expecting a final conference budget. We will have the next revenue forecast update next week on the 18th. We assume that the House and the Senate budgets will start coming out, a week or so after that. And then the governor actually has to sign the budget into law. So we're hoping session ends on April 27th, and then the governor will have time to veto things in the budget, and then that new budget would go into effect July 1. Along that way, I'm assuming if there are staffing reductions or other specific things that the agency has to deal with, we will be working on how we would operationalize those. We don't know specifics yet of how we would be instructed to do some of these cuts, whether there would be specific instructions or not, or if the agency directors would be left to do that. So as we know more, we will bring this back to the board.
One more piece, then we'll go to John's question. The inset purple bullet that says proposals are not introduced until after this meeting takes place, that is a structural piece of the legislative process. And so sometimes people will ask, why haven't the House and Senate budgets come out? They are required to use as the foundation of their budgets the result of the March revenue forecast. So by definition, the budget proposals never can come out until after the revenue forecast. In the same way that the governor's proposed budget, in this instance, it was the outgoing Inslee administration, has a budget that is produced in December based on the November revenue forecast. And that's why as the numbers get refreshed, the goalpost moves a little bit for the next part of the equation. And that's how we know you can always look for when the March revenue forecast is and go, oh, we're not going to see budgets until after that date. So just wanted to highlight that for many people are like, why isn't the legislature releasing a budget in February? They actually can't. Or, well, I guess they could, but then they'd have to release another budget after the revenue forecast because the benchmark is that meeting. So just wanted to highlight that. John?
With the budget submitted by Governor Inslee and the changes made by Governor Ferguson, including the two affecting us, how close do they come to the 12 billion savings?
There's still a lot of distance to make up.
Yeah.
So,
So Governor Ferguson's recommendations at the end of February were about $4 billion in additional cuts on top of the Governor Inslee budget. And so there is still quite a multi-billion-dollar. It's hard to know because you don't know if you're doing 12 minus 4 minus, I can't remember the exact amount that was in Governor Inslee's budget, but there is still several $1 billion to go. And we all don't know whether till after next week, whether the deficit is 12 or 15 or some number there in between. But there's still quite a bit of ground to make up.
there's some expectation that many of the things we discussed just now will be included in the final version.
I don't know that we expect it to be, but I say we anticipate that none of that is off the table, is what I would say. I know that's not hopeful.
Even if all of the pieces that all state, the totality, my understanding of the totality of what state agencies put forward was around $5 billion. And Governor Ferguson recommended $4 billion. Now that $5 billion doesn't include our extra fund pieces because they weren't really part of the official 6% exercise. So even if everything agencies put forward had been recommended, there would still be a multi-billion-dollar deficit for the legislature to address. So, and there's still a long way to go, John.
But just a point of clarification too, it's just, we need to get to a balanced budget, so it doesn't all have to be cuts. There can be additional revenue that's.
I have a question about the stabilization reserve. And if you can't or care to answer it, it's okay. Is there a value associated with that? I know what you said, 7% to 5%, but it's $100 million, $1 billion or.
Yeah,
more
no,
paying.
so the PSR reduction, is in the first year for PEB and SEB about $76 billion combined in the first year of the budget. And then it slows down and tapers off.
So let me ask this.
That's the amount attributable to what we would be freeing up,
Oh, okay.
not the total value.
Understood.
Another piece for our presentation, we won't go through all of the appendix, but I just want to highlight, and then I do want to do a quick pit stop on the fourth appendix. So we have four parts of our appendices. We have the directive from Governor Inslee with the freeze, December freeze. Then we have the OFM memo in late January asking for the budget reduction exercise from agencies. Then we have the 16-page budget priority document produced by Governor Ferguson. And then the fourth one is the one that I really wanted to highlight, which is the sheet that was produced for the agency reduction process and then published on OFM's website. And what I really wanted to draw people's attention to on this, Harry, this would be an area to be able to see some of the numbers like Tanya just described. The one thing that is that's slightly different than what was published, we added a couple of annotations in red in the far right column that describe the funds that each of these lines are attributable to, so that you could go back to that flow chart, multicolored box flow chart, and go, oh, we were talking about the big 721 account. These are the lines that relate to 721. Oh, we were talking about the far bottom right agency admin reduction 418 account. These are the lines that relate to 418. So we added in a little bit of that annotation to crosswalk. I know when you look at these budget reduction sheets and the public looks at them, it can be very overwhelming, even just within the healthcare authorities. A lot of people for PEB and SEB very naturally went to the second page and saw PEB and SEB and didn't realize that the way our agency organizes, we put all of the 6% admin at the top of page 1. And so some people looked at our agency reduction sheet and thought that HCA was managing the PEB and SEB account 6% reduction by putting it on the backs of state employees. Was kind of the question that was raised. It was like, no. The top of page 1 is the agency admin reductions, and that's where you get into the subtlety of all of our accounts. The bottom second page is really those other parts that the agency didn't have a target to hit, but still needed to contribute options for consideration. So I just wanted to orient people to it. A lot of people have seen this spreadsheet and just wanted to highlight those pieces and give those extra annotations. Tanya?
Yeah, and since we're pointing that out, Harry, the number I did give you will not match 100% what is on what you have. And that's because similar to the revenue forecast, we updated our quarterly modeling that went to the legislature for their version of the budget that will come out. And that PSR number I gave you was based on our most recent quarterly update, which had been updated since we submitted this.
Thanks. I hadn't really gone through this. Don't have the vision to be able to, but one of the items I noticed in there is something I've been interested in a long time. And I'd like to see it sometime in the future, the board to think about, is carving the pharmacy out of the managed care. I know that's not for discussion now, but it's just something I see in here that's long been something I've been interested in, so that we have one payer of the pharmacy benefit instead of just self-insured fund. We would assume that was managed care. I know that the managed care, I would assume they probably wouldn't be in favor of it, but we've carved some things out before, and that's one I've always had some interest in. Now I see it on the listing. Well, maybe it is a discussion in the future. Thanks.
And just highlighting here, you see that under the Apple Health section, but understand the applicability of that conversation to both programs. But I did want people to realize you were highlighting something that was technically under the Apple Health scenario. So this document is agency, and it goes to Medicaid, PEB, and SEB accounts, then it goes into Apple Health scenarios, and then page 2 goes into combined PEB and SEB scenarios.
Yeah, that's really a good clarification. Thanks. Anything else?
Any other questions?
We'll be back next meeting, Tanya, with budget. There should be releases of legislative budgets to walk through at the next.
How much is the bigger unit?
Let's go ahead and take a 10 minutes. Oh, do you have a question?
Do you have a question?
Yeah, I'm really curious about one thing. We keep hearing at the federal level a lot of vagueness about what's going to happen to Medicaid funding. And it sounds sometimes like it's very dire, and the amount of Medicaid funding that each state is going to be receiving would be significantly impacted by these conversations. I'm wondering if when they do these forecasts for revenue, and like that March 18th forecast, are they taking into account the potentiality of Medicaid, lack of Medicaid funding beyond what they currently have?
No, actually, I mean, it's so early, and it's in terms of what it means and how soon it could go into effect if it did, that no, this does not include those potentials. And part of it is there's just several different ways to look at it. So you wouldn't even quite know where to begin you know, where you would take those savings. And it, you know, could be very significant for the state of Washington because we're one of the 9 states that has a 50-50 contribution, so we pay 50% for most folks and 50%
Okay, well, if I could.
feds.
if
Other
I could
states
keep
have,
engaged,
you know,
I'd take that.
60-70% differential from the Fed. So ours is like the lowest percentage. So for us, we get hurt a lot more than some of the other states, if in fact that went through. So it's certainly a concern. But the floor is now set by law. So, all
Thank
right.
you.
On that note, let's take a 10-minute break. Thank you. Brett Mello, Brett Mello, our new Chief Information Officer, and Jean Louis will be doing a presentation on the updated benefits 24/7 that system. So go ahead, and you're behind tab 7.
Sounds good. Well, good morning, folks. New to the organization, I'm Brett Mello, new Chief Information Officer, so I manage the technology for our organization. And by way of an introduction, I put together just a quick slide, a little bit of my background. So my entire career has basically been in IT, but in the last 15 plus years, specifically as Chief Information Officer overseeing the entire IT operations for different organizations. I come to you from the provider space. So I come out of healthcare systems that I've been managing around the United States. Wanted to look at something slightly different, but I wanted to stay healthcare adjacent. And this was a great opportunity for me to not only be a part of a very exciting program, but actually in the state that I really wanted to be a part of. So my expertise expands beyond just technology. So I have more than just IT knowledge that I bring to the table. A lot in process improvement, organizational development, strategic planning, communications and things. So I have a very diverse background to bring to bear to try to help utilize technology most optimally to advance programs. So the one thing I wanted to share as we get going is just what we're doing with our people side of things and how we're going to be advancing the organization through the strategic use of people. We've got a new team leader that's going to be bringing the benefits 24/7 P1 development teams more closely together. We wanted to put a very specific focus with leadership of making these two teams really work well together. We've got a bunch of very bright people in these groups, but they come from kind of different worlds. And so bringing those folks under a common leader is part of the process we're working on now. We also have a new tester that starts on Monday. So as things get developed, before they go into production, we have a group of individuals who go through and vet everything and make sure that it works as expected before we actually go into production and expect it to work. Beyond that, we are looking at what other opportunities do we have for human resources in this group to help continue to advance and move this program forward through the innovative use of technology. So there's probably going to be more to come on that, but that's where we're at right now with some of the staffing elements in my jurisdiction. So,
Michaela, before we go, let me add one more piece. So these two positions that we're describing, the PERB IT lead as well as the tester, are examples of positions that didn't get refrozen, so to speak, in December and were part of that commitment because of the importance of our system stabilization. Assessing further resources, a gentle reminder, Tanya talked about this at the retreat. She'll bring it back with whatever's in the Senate and House budgets. But Governor Inslee's proposed budget, and this was not changed by Governor Ferguson, so it's de facto part of Governor Ferguson's budget at the moment, included funding of a specific decision package that the agency prioritized. We don't call it an IT resource package per se, but it had what was funded in the Governor Inslee's budget was 6 IT position FTEs, 2 accounting FTEs, and 1 additional resource within the outreach and training unit, which supports the benefits administrator out of the PEB division. All of those are still in play. there's this interesting kind of cognitive dissonance one might have with the statement I just made and the entire presentation Tanya just went through. But sometimes we live in that world, and it is possible that if that was adopted in the final budget, that we would see the potential for FTE reductions in one hand and FTE additions in the other hand. And I want to assure folks and the board that it wouldn't just be a complete swap, but we wouldn't move forward with IT resources. We would prioritize the IT resources and similarly identify how to comply with other budget reductions. So it's not a, +6, -6, nothing changes. The IT resources, if they are funded, are because everyone understands the criticality of them. And we would then proceed with those types of positions. So just wanted to highlight that, folks. Kyla?
Thanks, and Dave, you've heard me say this before, but welcome, Brett, and since you're new, just kind of adding in my day job, I lead the state HR division within the Office of Financial Management, and with regards to kind of QA testing, we'd love to partner with you. I know our kind of payroll folks and our HRMS folks have some insight with regards to like what to look out for as updates are rolled out and how they might impact kind of payroll offices across the state. So any opportunity to partner in that testing would be greatly appreciated.
Good morning. I am here to give an update on some of the stabilization efforts that we shared during the retreat. And Outreach and Training has been sending out weekly messages to benefits administrators with updates on the progress and fixes that have been made to benefits 24/7, as well as calling out new issues that have been identified. These messages note issues impacting all of our populations, including PEB, SEB, and our retirees. While some of the issues have impacts that are more global, many bugs are program specific, and that information is noted in the communication. The work on the IT teams are doing is much more expansive, but we're including those items that impact larger numbers of members. The messages are intended to give a snapshot of the work the team is doing for all the programs to stabilize benefits 24/7. In our early benefits administrator communications, we shared some of the stabilization strategies that would be our focus for the year. And we're starting to see some positive trends in some of the areas, especially with ticket backlog. Our ERB customer service team has made great strides in document entry, so we're seeing more normal numbers for this time of year with our documents. At this time, though, we do continue to see increases in accounting tickets and emails, and are continuing to employ strategies to address those like overtime. Our data team has developed a discrepancy report to identify certain discrepancies between account information in benefits 24/7 and Pay-1. The report went through thorough testing, and our teams began work on it last week and are working to resolve active discrepancies. The goal of this report is to identify discrepancies on a daily basis and to hopefully address those before they become issues for our members. Next slide.
One other thing I'll add for the group is, don't want to get into too much of the weeds on this, but we have worked with the IT team to adjust the deployment schedule, so it will be a little bit faster cadence, which hopefully people will begin feeling and seeing in our updates and in the system, resolution of things at a faster clip, if you will. So just want to highlight that there was an adjustment made on kind of the deployment schedule cadence that's being used.
Any questions? Excuse me, any questions? All right, thank you. So let's move on. Excuse me. Troy Klicka, you join us? Is he online? Okay, thank you. He's our Office of Legal Affairs section manager, and he's going to be bringing an update of the PEBB program appeals from the plan year 2025 open enrollment.
Good morning, everybody. My name is Troy Klicka. I'm with the Division of Legal Services. Let's talk about appeals. Next slide, please. So what I'm going to discuss today is an overview on what an appeal is, the processes that we use for appeals, and then we'll highlight January and February trends that we're seeing, like the most common appeals, and then just general trends. Next slide, please. So what is an appeal? Well, what we're talking about is a brief adjudicative proceeding, or BAP. And so that includes eligibility and enrollment determinations. So if you think about that, think about medical, dental, vision, wellness, flexible spending arrangements, dependent care assistance programs. What it's not is a care or pharmacy denial or a service denial. So if Kaiser has denied a bone marrow transplant, we're not the place that you appeal. Next slide, please. So there's processes with the program and there's processes with employers. The process with both is very similar. An employee or retiree makes a request of the program, and the program approves or denies the request. If there's a denial, then the appellant may request a brief adjudicative proceeding, or our term of art for appeal, and then that comes to my unit for processing. If somebody doesn't make that request timely and there's appeal rights that will have time on them, like 30 days, 60 days, depending on the type of appeal, then that decision becomes a final decision and is no longer appealable through the agency. Next slide, please. The process is similar for employers. The employer can approve it or deny it, and then similarly, the appellant can then go through the process of making that request again. Next slide, please. So if somebody does make a request, it comes to the Office of Legal Affairs, which is where I work, and we issue a confirmation letter. And that confirmation letter will say something about, hey, we've received your appeal, and within 10 or so business days, you should expect a decision. With roughly 98% of our cases either are resolved within 10 business days, or if there's a continuance, we send out a notice saying your case has been continued for X amount of days. And that is provided to the appellant, and we update our paperwork accordingly. Once that confirmation letter is sent out, then the case goes to a paralegal who processes the case. There's two types of cases that we don't take. So if something's untimely because it's late, or if it's premature because it's early and no decision has been rendered by either the program or the employer, then those are denied. Next slide, please. So what our office does is writes an initial order. An initial order is an agency decision on the request that the appellant has made. Presiding officer may issue a continuance, extending the timeline to issue an order. The presiding officer may ultimately either affirm or deny an order. So if affirming it would be saying yes, the program, or yes, the employer did the right thing, or denying it by overturning the decision and saying, no, appellant, you win because, and here's why. So if someone does not get an answer that the person was hoping to get, the person has another level of review. That level of review must occur within 21 days and can occur orally or in writing. And so so you could call up on the phone and say, I hereby request review. And that's good enough for preserving those appeal rights. And of note, the appellant and the program both have appeal rights when it comes to an initial order. So if something is completely wonky and the program says, hey, I think this is wonky and we want to appeal it, the program has the ability to do so. Next slide, please. So what happens next? Well, the chief review judge at the Board of Appeals in the Healthcare Authority will review or assign out the case to have a final order, which is the final ultimate decision of the agency. roughly 1 in 10 appellants requests a review of an initial order. And so what the reviewing officer does is evaluates that order and then will issue a final order. And the appellant can then either take that to Superior Court right away or seek reconsideration of that final order. And reconsideration usually means that there was an error somewhere in the final order. So let's say that the reviewing officer wrote that the person lived in Delaware when the person actually lived in New Jersey. That would be an error that could be corrected. But you don't have to seek reconsideration to go straight to Superior Court. Next slide, please.
Hey, sorry, Troy, before you move on to
Oh, yes.
trends, I just wanted to add one more piece one more piece of context. The Office of Legal Affairs is not part of my division. So when Troy said, the program can appeal, you might wonder about that. That might seem unusual, but we purposefully house this entire appeals process in a separate division, our Division of Legal Services, so that there is that, separation between the program and the appeal process. And that's why there is a bidirectional opportunity for appeal of various decisions. I also want to highlight that within the Office of Legal Affairs, and this is, I think, important because we start with the word office, that is an administrative unit of the healthcare authority. If there is some sort of additional fact finding that's needed, our internal legal folks in Troy's area of the Office of Legal Affairs can actually escalate the appeal and refer to the Office of Administrative Hearings, which is actually a separate independent agency. And then if a case or an appeal is moved over to OAH, again, the Office of Administrative Hearing, then their jurisdiction and their timelines and their process and deadlines for adjudicating, whether it's 30 days or 60 days or 90 days, all of that kicks in and they have the authority over all of that. And we no longer have, we're a player in that game, but we're not, our legal team is not the arbiter, so to speak. We've handed over the arbitrator, not the arbitrator, but the adjudicative role to the Office of the Administrative Hearing at that point. So just wanted to highlight that because some people might think that OAH is part of the agency, but OLA, Office of Legal Affairs, is part of our Division of Legal Services. OAH, separate agency, and that can be part of this. And everything that Troy just described is really how this agency for the PEB and SEB programs implements the Administrative Procedures Act. John, you had a question?
Yeah, am I correct to assume that a member would not appeal a provider decision through this process?
That is correct. The services pieces, like the denial of a particular claim, would go through the process that is under the plan carrier and that process, and then could end up in like an independent review organization review that is.
It doesn't come through here.
But it does not come through the agency. The agency's appeal process is about eligibility and enrollment. Plan appeals, in particular, the service appeals, are like completely separate and outside of the agency. Back to you, Troy.
All right. Well, let's talk about appeal trends. Well, why are we talking about appeal trends right now? Well, because in November, that's when open enrollment happens. And then the few months following that is when there's a lot of people appealing the choices that were made or various things that occurred during open enrollment. And so we call right now the cleanup time. And so most of the appeals that we get occur between January and April of each year. Sometimes it fluctuates. For instance, last year we had more appeals in March than we did in either January or February. This year we're on track to, I think February looks like it's been our biggest month. And so most of the cases that people appeal are on clusters of request types. So spousal surcharges. Why do I have this $25 on my account? I've never smoked in my life. Dependent enrollment. I thought I added my kid to my account, but there's no kid on my account. Where'd my kid go? Plan change requests. I want a Delta Care Dental, but I think I selected the wrong Delta Care Dental because when I went to my dentist, the dentist said they don't take my insurance. Medical. I thought I picked Kaiser, but I got UMP. What happened? And then retiree appeal concerns typically relate to reinstatement or in some cases, enrollment in general. Next slide, please. So here we go. Here is through February 27. Here's what here's what our numbers look like, and I've got some slightly updated numbers that I'll give you after we go through this. But as you can see, the spots highlighted in red are the categories where we had the most appeals. So out of both programs, you'll see that it's pretty similar where there's hot spots. So dependents are a hot spot with double-digit requests. Plan change requests for dental, largely because the Delta Care issue. Plan change requests for medical. As you can see here, there's a lot more in PEB than there are in SEB. And then spousal surcharges, which there's a little bit more in SEB than there are in PEB. And so program totals for January and February, I believe we ended in February with, let's see here, with 179 total appeals, and for January 156. And so that was pretty close between those 2 months. For March, the last time we ran numbers was on the 8th and we had, or the 7th, and we had 8 appeals. And so March has started off a little slower than with under 10 a week versus the 40 something a week we had in January and February. Typically, our appeals are between 800 to 1,000 per year. So as you can see, having 300 of them hit right at the beginning of the year is a little bit of a bottleneck. But as you can also see on this chart on the right, most of the appeals that we receive are timely. There's a few untimely ones and there's a few premature ones. If there is a premature appeal, nothing is stopping that person from later. If we say, hey, you need to contact the program first, then the person can go contact the program or talk to that employer and get an answer and then appeal that. So premature doesn't mean, oh, you don't get to appeal now ever. It just means that what you're appealing on currently is not able to be processed. I believe that's the last of my slides. If you have any questions, we have a handy dandy email address here. And I also have an email address, which is my first name, last name at hca.wa.gov. So
Yeah.
any questions?
Just quickly, you answered half of the question on the premature claims, but do you have any knowledge of the premature claims that were kind of denied because of the timeline that kind of rolled back up to a timely claim?
So unfortunately, we don't track that, and we tried to look that up, but in order to do that, we'd have to track each individual claim and go through and cross-reference it with every appeal that we've processed in the last however long. And so ultimately, we will see things that people will appeal again, and we provide them with written notice on how to go through that process. And so even if they don't appeal, they've at least been given an instructions on how to go about and do that correctly.
And I'll just say like kind of the why behind, or like what I'm looking for is the concept of like just kind of the accessibility of the communication and how many people are aware of like what process to follow so that they don't accidentally not get access to their appeal rights if they don't get the communication in a timely manner. Are you sending it via paper mail? Or
It depends on what the person has asked for. So some people will opt into e-service, so they'll get a secure email. Other people will want paper mail. And if a claim, or I'm sorry, a request for a brief adjudicative proceeding is indeed something where someone, if we say, hey, you need to go to your employer, a lot of times people will go to their employers and will never hear back because they've gotten it sorted out.
Any other questions?
Kurt, we see your hand.
Yeah, thank you. I don't have a question, but just a comment. I don't recall seeing this information before. Doesn't mean it hasn't been provided, because it's very likely I could have forgot. But I just want to say I appreciate the information and your slides. Very informative, very helpful. Thank you.
Thank you.
My one other piece of reminder for everyone is we have 780,000 members between our medical, dental, and vision benefits between the PEB and SEB programs. So yes, we have 300, I can't do quick math, over 300 appeals here for January, February. That's 0.04% of our total members who have without some sort of appeal process with us at this point. So just always like to provide people that context. It is a lot of work. It's an important process, and it's a big responsibility, and it also does represent a very small part of the overall population. The vast majority of times there are things, as Troy said, that, especially if the decision is premature, the outcome that the person is seeking may very well be resolved without having an appeal process. So.
Can I ask one question? Please? Troy, thank you for the information. I think Kurt's correct. We haven't had this before. It's nice. It's helpful. But is there a way to quantify what percentage of appeals are approved over the course of time? I mean, typically 7 out of 10, or I mean, is that a fair question to ask? I don't know. If it's
So-
the answer.
So if I'm hearing you correctly, you're asking what percentage of appeals are ultimately approved and over like the request that the person's making. Give me just 1 second and I will see what I can pull up here. Generally, most appeals are denied because people are asking for things that are outside the rules. And so let me see if I can find something from the first quarter here.
Right, well, you look that up, I think it also does depend a little bit on the topics. So for example, retiree reinstatements. There is a part of the process which is very challenging for folks when premiums go up, and that changes in January. And maybe the correlation with any changes in pensions received if people are on a pension deduct. And if that premium increase then exceeds the ability for the draw of the pension amount from DRS that they've signed up. And a reminder, about 2/3 of our retirees use pension deduct to automatically pay their payments. But if the amount that needs to be withdrawn can't be withdrawn from the pension, we can't take a partial amount. DRS can't send a partial amount. We can't receive a partial amount. So those people in that situation are removed from pension deduct, and then they have to start doing individual premium mailings or sign up for electronic debit from a bank account. And so there are times where that leads to, even though we try very hard to get people aware in December that with the accounts that might happen to, there are people who then fall behind on a payment and they seek reinstatement. We have a lot of grace, especially if the account is in that situation, or it's kind of the first time that that's happened, where we try not to have a very hard line whenever it's come to those types of circumstances. So that type of appeal is much more likely to be approved, or I get confused as to approved or denied, but it's the outcome that the appellant wants is granted, is the way I think of it. And similarly, we have a lot of understanding, especially at the beginning of the year, about the Delta confusion, especially if somebody signed up for the HMO plan and they don't have a provider within 50 miles. Very clearly they meant the uniform dental plan. So we have a lot of grace there. So there is a little bit of a grace, if you will, that may play out in the numbers depending on the exact topic.
And I wasn't trying to infer a high approval rate, denial rate is good or bad. I would hope if the process is working, that they've already most people have had a fair hearing at the lower level, that, that suggests to me, a high denial suggests to me that the process is working at the lower levels, but I don't know. But
yeah, and I just wanted to give that context to give Troy a little bit of time to look up whatever he's looking up. Troy, did you have something else you wanted to share?
Yeah, and I found it. Yeah, so and this is specific to PEB for last year, so 2024, we out of 456 total appeals, we affirmed 224 of them, so roughly about half. Now, however, when it comes, like Dave was saying, it really depends on the category. We approved 72 retiree reinstatements. So even though we denied roughly half of the cases total, categories like retiree reinstatements were approved in droves, and a good chunk were dismissed. And so even though we are denying cases that ultimately go to the end, what we try to do is clean things up before they get to the end, before there's an order. So dismissing roughly about 60 cases were dismissed as moot. Why? Because we were able to work with the program to get a fix. About 16 cases were reversed or overturned. Another 12 were approved for another reason, and about 30 other cases were withdrawn or corrected because there was a settlement or an approval outside of the appeal process. And so the appeals, even though the appeal shows about half of them were denied, the incredible amount of flexibility that the program provides, and like Dave was saying, that grace that's given at the beginning of the year really helps to get people who kind of fall between the cracks in those gray areas. And so it's a very flexible system.
I was just gonna add, so there's an opportunity then to appeal the Superior Court if they're unhappy with that, and just sort of say, these guys are doing a really good job. I think right now we have 3 cases in the Superior Court, all related to eligibility. So I think that's just a testament to what a good job that office is doing.
Great. Any other questions? All right, well, and thank you, Troy.
Thank
So
you.
let's go on to our Medicare update and ask Laura Ryan from our retiree benefits and Molly Christie from one of our fiscal analysts and Luke Dearden, one of our clinical pharmacists, to please join us. And they'll be coming together to bring us some information regarding the PEB program's Medicare population. And your presentation materials are behind us. Excuse me, tab 9.
And we have Laura virtually and Molly and Luke.
Good morning, Chair Lindeblad and members of the board. I am Laura Ryan, and I'm here to present the Medicare updates along with Molly Christie from our finance team and Luke Dearden, our clinical pharmacist. Next slide, please. So today we'll be talking about coordination of benefits savings bank 101. We'll also be talking about coordination of COB savings bank financial insights, Medicare Part D transition updates, and a discussion around the Medicare drug price negotiations.
Laura, as you get started on COB Savings Bank, I want to say one thing to level set for folks as to why we're doing this presentation and talking about COB Savings Bank, because I don't want people to get the wrong idea about why we're bringing this information. The board's very aware that over the years, there have been a lot of challenges with UMP Classics premium. We had back-to-back 20% increases. Last year, the board made the decision to move the Part D formulary. It had a lot of downward pressure on premium. A lot of people were very happy about that. We'll also talk about the challenges that some people faced in that transition, but that's not the end of the story. We all know that we will continue to talk about premiums, and many times there are upward pressures on premiums. So I have a commitment to come back to the board with levers that you might be able to pull in the future. You pulled one lever to put downward pressure on the premiums last year, the Medicare Part D transition. Another lever that you could pull in the future is the COB Savings Bank. And so that's why we have some fiscal insights, and we wanted to start orienting people to this particular topic, as it may be a lever that you want to consider in the future. We haven't even begun the rate setting process in earnest for 2026, and I'm not saying that's something that would or wouldn't be approved, teed up as a potential recommendation, but it is one of those levers that the next time you feel the need to pull a lever, it might be one that you want to pull, and so we just wanted to begin orienting people. But I don't want people to think that this is affirmatively teed up as another change in absolute, but we just want to be responsible outside of an emergency situation, orienting you with time and deliberation for you to understand the topic. So with that, Laura.
Thanks. So yeah, we'll start out with the COB Savings Bank 101. Next slide, please. Okay, so this is a review of cost saving measures. So the board has previously been presented with ideas for UMP Classic Plan cost savings, as Dave was talking about. So opportunities, cost saving opportunities for members with Medicare. And in this first section of the presentation, we're going to look more closely at one of the areas we have formally discussed. And as we dive a bit deeper into the COB Savings Bank benefit, we'll briefly review the different ways a plan might design coordination of benefits or COB provisions. Next slide, please. So in order to dive into the COB Savings Bank overall overview, I'm going to start by reviewing the different ways that plans coordinate coverage with Medicare as the primary payer. So under a carve-out plan, The plan calculates what it would pay towards the claim or the normal benefit, and then it reduces its payment by the amount that Medicare pays. Under a maintenance of benefits plan, the plan subtracts the Medicare payment from the total allowed amount and then allows the plan's benefit limit, applies the plan's benefit limits and cost sharing to whatever amount remains. And under coordination of benefits, which is what the UMP structure is now, Medicare pays first, and then the plan pays all amounts not covered by Medicare up to what would have been paid without Medicare. So as it was presented in an earlier meeting, there are 12 states that offer plans that coordinate with Medicare, but only 6 of the 12 states have coordination of benefits or COB plans as we've defined here. And then for your interest, those states are Florida, Mississippi, Montana, Virginia, our state, Washington, and Wyoming. Next slide, please. So this is an illustration of how these coordination plans work. In this theoretical scenario, a provider bills $200 for a service. The plan allowed amount, which is also the Medicare allowed amount, is $100. In each case, the plan has a 15% member coinsurance and pays the remaining 85%. So under a normal benefit where the plan pays primary, it would pick up $85 of the $100 allowed amount. But Medicare is the primary payer, and Medicare will cover 80% or $80 of the $100. So under the carve-out design, the way it would work is the plan calculates what it would pay toward the claim, which is $85, then reduces its payment by the amount that Medicare pays, which is $80. And so then the plan would pay $5 and the retiree would pay the remaining $15. That's the carve-out. So the next one is maintenance of benefits design. The plan subtracts the Medicare payments from the total allowed amount, or $100 minus $80, and then applies the plan's benefit limits and cost sharing to whatever amount remains. In this case, $20 remains, so the plan covers 85% of the $20 or $17, and then the retiree would pay the remaining $3. Under coordination of benefits, which we are most familiar with, our UMP plan, Medicare pays first. In this case, it is $80, and the plan pays the rest of the allowed amount, which is $20, and the retiree would pay nothing. Next slide, please. So the our UMP plan with Part D is a self-insured coordination of benefits plan with Medicare Part D prescription drug coverage. For Medicare covered services, a provider will bill Medicare. Medicare pays the claim first, and then it is processed and the claim is sent to UMP. UMP is the secondary payer. And for most covered services, UMP pays the rest of the Medicare allowed amount and the member pays nothing. If the service is not covered at all by Medicare, that is the instance where UMP is the primary payer. So what is the COB Savings Bank? So the UMP plan has a unique feature that allows members to use the savings they accrue in their COB savings bank to cover out-of-pocket costs for the UMP deductible and services that are not covered by Medicare. The savings bank, COB savings bank, accrues based on what the plan saves for claims when Medicare Parts A and B are the primary payer. And regardless of the total COB savings bank accrual, the member can only be reimbursed up to the total actual out-of-pocket spending. So a member would not be reimbursed beyond their out-of-pocket spend. So how does it work? Excuse me, next slide, please. At the beginning of the year, members first have to satisfy their Medicare and UMP deductibles. And then once the deductibles are satisfied in full, when a member receives more healthcare services, UMP usually pays less than its normal benefit as the secondary payer to Medicare. The difference between what UMP pays as the secondary plan and what they would have paid if they had been the primary payer accrues as the COB savings. So it is UMP Regents that keeps track of how much a member has paid out of pocket during the year. If the COB savings accrues, then Regents may send members a COB savings check to reimburse out-of-pocket expenses the member paid earlier in the year. And again, the UMP Classic Medicare does not reimburse members for more than they have actually paid out of pocket. So here we have another example, looking at the same structure that we looked at before, a claim that was billed at $200. The Medicare allowed amount is $100. Medicare is going to pay their 80% or $80 on this claim. The remaining amount is $20. Now, if the UMP allowed amount is also $100, the UMP normal benefit, had they been primary, is 85% or what would be $85. UMP pays $20. The member pays nothing. But as we can see on that bottom line, the 65, so the COB savings is $65, which is the $85 minus $20, which equals 65. So that is the normal UMP benefit not paid on this claim, and it is tracked as part of the COB savings. And in this example, you owe $0 because the provider does accept Medicare. You might still have to pay coinsurance and deductible amounts if you've not fully met those, or if Medicare doesn't cover the service. Excuse me. Next slide, please. So some considerations with the COB bank. Members who use more Medicare covered service are going to accrue greater COB savings. So the savings can be used to reimburse members for monies paid for benefits that are already received but are not covered by Medicare. And the COB Savings Bank lowers or eliminates cost sharing for members who use non-Medicare covered services. But it's important to note that the feature does increase overall plan costs and therefore the monthly premiums for all plan enrollees. And I'll pause there. I don't know if you have anything to add, Dave, before we turn it over to Molly.
I don't have more to add. I think Molly's financial considerations are good context.
Thank you, Laura. I'm Molly Christian with Earth Finance. Excuse me. In the next couple of slides, I'll share information on the impact of COB Savings Bank to premiums. So this table provides a summary of costs and utilization of the COB Savings Bank in 2023 and 2024. We see that more than 90% of UMP Medicare members were reimbursed COB savings in each of these years. The average amount reimbursed per utilizing member was $215 in 2023 and $221 in 2024. If we divide the total claims expense for COB savings across total membership in the plan by 12 months, the cost was approximately $17 per member. So this per member per month cost reflects the approximate amount of monthly premium that is attributed to the COB Savings Bank. The data shows us that almost all UMP members, retirees, are reimbursed for COB savings. As you saw, on average, the amount is near the plan deductible of $250. The total claims expense for COB savings, as Laura mentioned, is dependent on how many members are enrolled in UMP Medicare and the volume and types of services they use. So the COB savings accrue for Medicare covered services and may be used for out-of-pocket medical expenses, such as the UMP deductible or non-Medicare covered services. The more Medicare covered services and out-of-pocket expenses a member has, the higher their COB savings reimbursement. Based on historical utilization, as you saw on that last slide, we estimate that eliminating the COB savings bank feature could reduce monthly premiums by between $15 to $20.
I'll add a little more context here. So I think an important piece is your Molly bookend, the numbers, one could look at it and go, oh, they're very similar. It could be a wash at the end of the day, because you're offsetting the amount that people are receiving generally in the monthly premiums. I think one of the things that is an important consideration here, if this is a lever ultimately that the board would ever want to pull, is just to keep in mind that Molly's described the averages. There are some people who are, every year, there are some people who have very large COB reimbursements. And so there's a wide range within that average, and we can talk about that at some point if the board wants to pursue this idea further. And also, there is that piece where it kind of does feel half a dozen, six of the other. Do you want to have higher premium with this type of benefit? And we get questions periodically. Why did I get this random check in the mail? And while it might seem like a wash at the end of the day to take from here and give from there, it also does fit the theme of administrative simplification. There is a whole work stream that Molly described that's behind the scenes at Regents to monitor on a person-by-person basis and track all of these pieces. And there is an administrative cost that is related to that for people to be aware of. So there's a lot of different ways to think about this. And just because the numbers are so similar in what people are receiving the benefit on average versus the average premium, there are other considerations to think about as well. And I think myself and Kyla first.
Is there any understanding or speculation on how like a deductible might influence someone's behavior in utilizing their benefits? Does that question make sense?
It does. I think here, though, the part is it's a reimbursement that is coming sometimes. I think the checks are almost quarterly. They're not really on a monthly basis. So that's the distance between the payment of the deductible that they already have to reach before the accrual even begins to happen, and the reimbursement later for other services that ends up, it's almost too disconnected in time for people to go, oh, I'm going to front my deductible only to get reimbursed by it 4 months later. So we're not sure that there's the outcome. Normally a deductible might people will think of it that way. They might go, oh, I don't have this up front, and they might assess their initial services as to where they are not. But here, the reimbursement of that essentially is almost too divorced for it to make it in most people's calculus.
Well, that's what I mean is it feels like there's because what I hear is like, okay, it's kind of a wash, but then you add in kind of human psychology to it, and like the thought or the hypothesis, maybe it's not, because if I have that deductible, it's going to influence my kind of hesitance to use my benefits. Whereas if I don't have that deductible, would it change my behavior to use my benefits more to where the cost would change?
Yeah, I think at the same time, they still have to meet the deductible up front in order for this accrual to ever happen. So whether there is the COB or savings bank, the initial deductible barrier that you're describing that might be in the individual psychology is there regardless of whether the COB savings bank is part of the equation or not. Elliot, you were next.
Some feedback I have gotten, and I don't have the percentage of the population who said this, but I have heard, why are our premiums going up so that these people can benefit from the COB savings bank? I don't use it. I don't benefit from that. And I resent the fact that my premium is going up for them.
That's a classic insurance pulling question, but you're right. That is a very, that is definitely a piece of this. That is another factor of the equation. Scott?
I got a question regarding numbers on slide 14. It was about a 7, almost an 8% reduction in members COB savings, yet the percentage was only 1%. What happened to all those employees?
You mean the percentage using COB savings?
Yeah, but the percentage was pretty much constant, 94 to 93, yet the number of employees went down. Do we have a reduction in force?
Well, so this is retirees, but also remember that between 2022 and 2023, and 2023 and 2024, we had back-to-back 20% premium increases. And each year we lost between 8 to 10,000 live
I'm sorry.
in
Yeah,
UMP that switched to
where it was
either
right there.
Primero or.
Yeah.
Yeah, so that's where the
Sorry, I had
numbers.
to take a little
Yeah.
break to do something and I came back and I saw this number and now I know.
No, that was a great question because we didn't mention that point until you asked. But that's the context of why the denominator on that top row changes so much. There was a substantial loss in overall enrollment this year. Any more questions in general? Again, I sometimes talk about topics come in like a 3 or 4 part mini series. This is just part 1. So more to come in the future about this topic. But again, we just want to start to prepare people for like the type of levers when we're not in. But I think we can go now to the Part D transition with Luke.
Oh, that's still me. Is it? I'm sorry, Luke, that's you. Nope, that's me. I'm so sorry. I pulled up my presentation out of order. Okay. So yeah, this section is to just go over some of the things that we've seen with the Part D transition, and some of the feedback that we've received. Um, we talked about this a little bit in the meeting last month, that one of the biggest challenges that we had was our enrollment file issues. So those issues, they affected about 500 members that were transitioning from UMP into the United Healthcare plans during open enrollment. The most important thing to note is that we have since resolved these issues. And the challenge, it was related to the complex way that information is shared between insurance carriers. All changes for Medicare enrolled members have to get approval through CMS, Medicare and Medicaid services. And what was happening is that they were not receiving the cancellations for the UMP enrollees prior to getting the request to enroll members into the United Healthcare plans. And that resulted in some enrollment discrepancies, some delays and denials. But as we discussed, we have since resolved these. Um, and our internal teams really worked tirelessly to make the necessary logic updates and corrections to files to ensure that they contained all the data necessary for Medicare. And we have altered processes between HCA and our plan carriers to prevent this kind of interference in the future, when we have members that are making changes between Medicare plans.
And Laura, I want the board to know that when you said about 500 members that were transitioning UMP to UHC were impacted, that was about half of the enrollment that was switching between those plans as a result of fall. So the sequencing of that data went in the right order for half of the population and not the other half. But wanted to give the context.
The next piece of feedback is some frustration over members now being subject to the income related monthly adjustment amount, or IRMA, as it relates to a Medicare Part D enrollment. So the IRMA amounts, they are determined by Social Security, and they are based on 5 income brackets. Most of our members, if they are subject to IRMA, they might fall within that first bracket, which is going to be an IRMA payment they need to make of about $13.70 per month. And for most, or for really all members, the IRMA deductions are still going to be offset by the significant monthly premium reduction. And this is specifically in regards to the UMP switch to the Part D structure. Next slide, please. This is the IRMA bracket grid, you can see what the top income limit is for an individual, the top income limit for married filing jointly, and then what they might pay for their IRMA. Again, it is determined by Social Security, and all that communication happens between the member and Social Security, Medicare. We don't have access to know who is paying an IRMA and how much, but you can see even paying the top IRMA amount of $85.80, that is still going to be less than the overall premium reduction savings that was $113.58 per month when we compare the monthly premiums to 2024 for that plan. Next slide, please. The other area to talk about is that some members were unhappy that they can no longer use manufacturer coupons for some of the more costly prescriptions. And the reason for this is that enrollment in Medicare Part D, it does mean that members are subject to the anti-kickback statute, or the AKS. And this is a federal law which prohibits companies from offering anything of value in exchange for referrals to federal healthcare programs. Participation in Part D coverage allows for utilizing some other things that may not have been available to folks before. One of them is the Extra Help program that's administered by Social Security, and it is a resource-based program, and if eligible, it helps pay for the monthly premium amount in regards to the prescription piece. And it can also help pay for some or all of the out-of-pocket costs for prescriptions. Members also, yes.
One other thing that I want to add about the manufacturer coupon piece is to remember that the manufacturers in a coupon world can pull those coupons at any point. And so part of the factors to think about is the more predictable nature of the federal subsidies that are able to be leveraged with Part D versus the potential unpredictable consistency of manufacturer coupons. So there was a piece of that we talked about as we were going through the Part D analysis last year. I just wanted to remind people about that as well, because there are definitely people who are very frustrated at not being able to use specific coupons, and also an acknowledgement that those coupons are never guaranteed and often can be changed by the manufacturer at different points. So it's just there's a factor there to think about. John?
A point of information as a consumer, Medicare consumer, I find sometimes that the pharmacist will say, I didn't process this through Medicare, I used a coupon. And sometimes and that's the benefit of going to a pharmacist who knows all of your prescriptions and knows you. That's another thing that can happen.
Yep. That is a real thing. In my time in Sheba, I would see that often. It's not something we would want to encourage people to do. But yeah, sometimes a pharmacist may offer that. Excuse me. And one other thing to note is that with participation in the Part D, folks do have that $2,000 cap. And sometimes when I've received complaints about not being able to use the manufacturer discount, I'm able to break down the math between what the premium savings overall is for the year when compared to last year. And then how much, there may not really be much of a difference at the end of the year if they are indeed hitting that cap. And then we kind of break it down per month. So that is one thing just to also be aware of. And the last point is that members also have the opportunity now to participate in the Medicare prescription payment plan for covered drugs. Excuse me. And this allows members to spread out their out-of-pocket costs for over the course of the year. So sorry, my cough is catching up to me. And then moving on to the next slide. Another thing that I've received a lot of feedback about is some members have felt underinformed about UMP's switch to the Plan D structure. And when we do receive feedback like this, we are providing a list of all of the different communications that were either mailed or posted online. And then we have, within the past month, added a Q&A to the retiree section of the HCA website that will direct members to the appropriate sources for understanding and utilizing their benefits under the new plan structure. And that is titled, Learn About Your New Medicare Part D Plan.
Laura, I'll give your voice a break. This is also why Laura's remote today, for everyone's benefit, hers and ours. I did want to say on communications front, just to step back to IRMA for a moment on communications. I think one of the significant critiques that's been raised by some of our members is, where is HCA's information about IRMA? And historically, there has not been a lot of information about IRMA because the vast majority of the portfolio wasn't Part D, and so it wasn't as prominent a feature. Now that virtually all parts of the portfolio are Part D, we're going to be beefing up some of our ways that we describe IRMA. It is a challenging piece because A, we don't give tax type advice typically. B, it's hard to know exactly who is hit by IRMA because we don't have a window into everyone's income, but we can be more directive about there's a thing called IRMA and it's not a hurricane. This is what IRMA relates to and how you can find more information about it. And so we've talked with the communications department team here about how we will incorporate some more information in the enrollment guidebooks going forward, and that we will find some information, some way to acknowledge it on premium rate sheets so that people have a way to crosswalk and go to information. And we'll even revamp some of the things online where we have sections that are like how you pay for your benefits, and have a subsection that describes again, what IRMA is, why you might need to know about it, how you get more information by looking at the Social Security Administration information. So just want to say that there's a commitment to expanding that description of that, since it is now a more stable, since Part D is more of a staple feature of the portfolio, it's time to add more content about that, even if we can't say, member X, your IRMA would be Y, we can at least get them to the information about how they can understand what the implications are. So hopefully that was a good little pause for Laura, but Laura has one more slide.
Thank you, much appreciated. Okay, so my last slide is the good news, because we've also received happy feedback, which is that the premium decrease has been very well received, of course. The change to the Part D prescription coverage has resulted in the monthly UMP Medicare premium decrease of $113.58, as we discussed earlier, when we compare it to the 2024 premiums. And without this change, the monthly UMP Medicare premiums, they likely would have seen a significant increase in 2025 of $171.03 when we compare it to the 2024 premiums. So overall, that change resulted in significant member savings, which is a swing of about $284.61 in monthly premiums, and a difference of $3,415.32 annually. So overall, that has been a wonderful change for our retirees.
And Laura, that's per enrollee. So when someone's covering themselves and spouse, that would be over $6,800 in annual premium difference, a swing on what premiums were projected to be without the Part D switch to what they are with the Part D switch.
Yes. And that concludes my portion. So now I will turn it over to Luke.
Can I ask a question?
Please.
Yeah, Laura, thank you very excellent presentation. But I had a question going back to the IRMA. I heard it said twice, I think, about Social Security. That the income level is modified adjusted gross income. Social Security. Those are all sources of income, right?
So I wondered if anyone asked, this is where I planted that seed. We don't provide tax advice, and I don't know that we're experts on what is counted within the MAGI calculation. I know there's a great debate as to how much of Social Security payments themselves are part of the equation, but there is MAGI, modified adjusted gross income calculation that looks at various sorts of the retiree income, and that entire process is administered by the Social Security administration. But that's an example of something where like, I don't think the healthcare authority should be in the position of being the full adjudicators of what income counts, but we should be able to point people to a resource that can help them understand that.
And I totally agree with that, that somebody has retired income coming from other places, files their taxes. I think that all sources. But the other thing is, I don't want to sound judgmental, but for a retiree, married filing jointly, pay $13.70, be in that income category isn't exactly a bad place to be. I mean, 212,000 to 266 income for retirees, not bad.
We want people to understand the implications. And so that's why we have things like these charts so people can look at them and understand the impact of them. Yeah, I think the important part from I think my perspective and our perspective is to have people be aware of those impacts and that information. And, the state doesn't set the income levels, doesn't set the amount that's related to each of those income brackets. I'm aware that originally when IRMA was created and the 2003 Medicare Modernization Act, it didn't have 5 income bracket levels, that there were brackets added over time by Congress. So it is a completely federally regulated thing, but I do think it's important. Again, now that we have the vast majority of the portfolio is Part D, or if you have prescription coverage, you are Part D in the PEB portfolio now, for people to be aware of this information as they pick a plan, because they could always pick a plan without prescription drug coverage in the portfolio and then seek prescription drug coverage outside of the portfolio and think about the implications of IRMA wherever they are.
I had one thing to add to that too, is that the IRMA it's a 2-year look back. So often people who are subject to IRMA, it happens at the very, very initial part of their retirement because it's looking back to when they were still working and earning. So it's very possible that people have an initial IRMA and it drops off, as they continue on into retirement.
Another piece of retirement factoring insights as to the difference between retiring in December versus July.
Indeed.
Or January. All right, I think we'll go over to Luke now.
Yes. Good morning, Chair and members of the board. My name is Luke. I'm a pharmacist here at HCA. And I want to, I guess we're going to switch gears a little bit here, and I want to provide an update on the Medicare drug price negotiations occurring at the federal level. So next slide. So the Inflation Reduction Act that President Biden signed in 2022 required CMS to negotiate drug prices with drug manufacturers. The first round of negotiations actually took place last year in 2024, and the prices will be effective 2026. Drugs eligible for negotiation cannot have any generics available, and they have to be on the market for at least 7 years for small molecule drugs or 11 years for biologic drugs. And then kind of as a caveat there, drugs that are selected for negotiation must be covered by all Part D plans. So there were 10 drugs that were negotiated last year for effective year 2026. There are 15 eligible for effective year 2027, 15 eligible for 28, but that also can include Part B drugs, so provider administered products, and then 2029 and beyond, 20 drugs are eligible. Next slide. So these were the 10 drugs that were selected for 2026, and CMS has since concluded their negotiations. Eliquis at the top of that list is an anticoagulant. It's the highest grossing Medicare drug. There are some diabetes drugs, Jardiance, Januvia, Farxiga, Entresto is a heart failure drug. Enbrel and Stelara are biologic drugs for a variety of immune-mediated conditions. Imbruvica is a cancer drug, and then Fiasp and Novolog are short-acting insulin products from Novo Nordisk. And then Xarelto is another anticoagulant as well, the third row there. Oh, also I wanted to mention that CMS estimated that 8.8 million Medicare members used at least one of these drugs in 2023. And that's out of about 54 million total Medicare Part D members. Next slide. So to provide a summary of the negotiations, in August 2024, CMS announced results from the first round. Discounts compared to list price of the drug range from 38% for Imbruvica to 79% for Januvia. I want to point out here that plans for many of these drugs were already receiving discounts compared to list price in the form of rebates. So these discounts off of list price can be misleading, and that's particularly true with a drug like Januvia. It's a drug for diabetes. Diabetes has a lot of competition in that space, so diabetes drugs are very highly rebated products. So 79% is certainly overstating the true discounts that plans are receiving. Conversely, though, for a drug like Imbruvica, it's a cancer drug. Cancer drugs are not highly rebated products at all if they have rebates. So 38% discount on that is pretty accurate of the true discount. And I would say it's actually a very good discount as well. So per CMS, if these prices would have been effective for 2023, Medicare would have saved approximately $6 billion, and that is estimated net of existing rebates that plans were receiving. And then they estimate $1.5 billion in savings for members across Medicare programs. Next slide. So moving on to the next round of negotiations, which is already underway or is beginning. It'll be taking place throughout 2025. We have 15 products, and these were chosen because they are the highest grossing remaining drugs that qualify for the negotiation program. And by the way, they're also listed from highest grossing to least lowest. And I can tell you that Ozempic, Rybelsus, Wegovy, those are all semaglutide products. That is by far and away the highest one on this list. I think when they did the look back, I think it was November 2023 to October 2024, those products had about $14.5 billion in gross spend across Medicare. And then Trelegy Ellipta, which is an inhaler for asthma and COPD, that's second, and it's like somewhere between, I believe, 5 and 6 billion. So quite a jump. We have 3 cancer products here: Xtandi, Pomalyst, and Ibrance. I'm keeping a close watch on those just because of what I said earlier about cancer drugs and the first round achieving a pretty impressive discount on Imbruvica. So I think that's encouraging. OFEV is a drug for pulmonary fibrosis. Linzess is an irritable bowel syndrome drug. Calquence is another cancer drug. Next slide. Ostedo is an interesting product. It's for tardive dyskinesia and also Huntington's disease. Brio ellipta, another inhaler. Tradjenta for diabetes. Xifaxan for irritable bowel syndrome again. And then Vraylar is an antipsychotic. So that's the first antipsychotic that will be negotiated. And then Janumet diabetes or Tesla is a drug for a few conditions, but like for psoriasis is one example. So those are the drugs for 2027, a lot of interesting products, and we look forward to seeing what happens. Yeah, you have a question.
Yeah, I only know what I read in the newspaper, but there's been a lot of discussion about this whole thing going away under this administration.
So that's actually my next slide. Yeah. So looking forward, I didn't want to speculate on this, so you'll see I have literal quotations from a CMS press release from January 29th of 2025, which was after the inauguration. And the source for this press release is on the slide as well, if you're curious. But basically, it says lowering the cost of prescription drugs for Americans is a top priority of President Trump and his administration. CMS is committed to incorporating lessons learned to date from the program, and CMS intends to provide opportunities for stakeholders to provide specific ideas to improve the negotiation program. So I take this as positive. I see this based on this program moving forward, at least for now, but anything could happen, I guess. And it sounds like President Trump wants to move forward with this, but he wants to make it better than President Biden would have done. In his nature, I guess. That's what I don't know. That's the vibe I get. But so it looks like this is moving forward for now. And that's it. I'll take any other questions you may have.
This will be a much easier question. Going back to page 25, I believe, on your last bullet, you said drugs selected for negotiation must be covered by all Part D plans. Does that I take it to mean, I'm in a Medicare plan and I have a private plan D. Would that be covered by this?
If you have a Part D plan, drugs selected for negotiation need to be covered by that plan. And
it doesn't have to be a Medicare Part D plan. Am I correct?
That's what we have.
Okay.
I think we'll bring back an answer to that one because it seems like a simple question, but I don't want us to speak out of turn. So we'll
be
follow that up.
specific about the situation.
Your question is really, does all Part D, what does the phrase all Part D mean on this slide?
Right, is it just Medicare Part D?
I see.
Or is it, I have WellCare insurance, or I think it's Aetna, or is it Cigna? Everybody's consolidating, so there's an Aetna plan, I believe, or a Cigna plan, drug plan.
We will follow up, Elliot. Like
I was trying to not ask you a difficult question.
The key part is, what does all mean?
What does all mean? Thank you. Yeah, I thought it was simple.
Yeah, John, do you have a question?
Yeah, keeping with my political question earlier, given the fact that the administration has moved pretty quickly in certain areas, were they basically to take away all these discounts in 3 months, What's the impact to us? The PEB.
So I'll take that one, Luke. I think a big part of right now, and this goes back to the Medicaid question earlier, what happens to the state budget if something is done at the federal level about Medicaid funding? There are so many variables inherent to it that we really have to wait and see what the exact
But it has
proposal
an
is.
impact, that's the
But
question.
yeah, there likely would be an impact, and we'd have to see exactly how that impacted things. And even at the federal level, certain things, the timelines that are proposed are achievable, and sometimes they're not, and sometimes there's litigation about what's achievable or not. I'll go back to the general statement of when we have things that impact our plans, they generally change on January 1 of each year. So there would be, hopefully, the incorporation of whatever is happening at the federal level. We would do the best we could with the projections we're making at the time in order to hit our open enrollment. And we will just have to wait and see exactly what is proposed. So unfortunately, that's the best crystal ball we
I
have.
just wanted to wade in a little bit. Yes, that's.
Yeah, the classic lawyer, everybody who's a lawyer, it depends. We'll just wait.
Yeah, I'm really glad that you included this presentation. Yesterday I read through all of the correspondence before I read through anything else, and I was fairly shocked by a lot of the content in a lot of those letters. And then I read the briefing book, and then when we got to this part of the briefing book, I read through it, and I saw that much of what had been discussed in those correspondent letters was addressed in this presentation. So I'm very thankful that obviously you had some concerns as well, and you addressed those mostly in this presentation. I am concerned, like John mentioned, about what could potentially happen if the drug negotiation and the negotiated prices were to go away, but I will stick with Luke's optimism for the currently and hope that it remains that way. So thank you.
Any other questions? All right, thank you. So it's time to get on to our provider prior authorization process legislation. And I'd like to invite Heather Schultz and Jenny Pfister to the table to do the presentation about this. Thank you.
I'm Heather Schultz. I'm the Associate Medical Director for Employee and Retiree Benefits, and I'm presenting today with Jenny Switzer.
Hello, Jenny Switzer, Senior UMP Account Manager with the Uniform Medical Plan. Marianne, remember when you said at the beginning of this meeting you were hoping to be done before 11:45? You should have knocked on some.
I wished.
You said it out loud.
That was my mistake. So we'll be providing an overview on prior authorization as well as legislation that impacts that process. The beginning of this presentation goes over what I think of as the what, why, and when of prior authorization, starting with this first bullet point, which provides a definition. Prior authorization is known by several different terms. It can be known as pre-authorization or pre-certification. Sometimes those are shortened as prior auth or pre-auth. And all of those terms describe a health plan's approval for certain services or supplies or prescription medications before those claims or bills are covered by the plan. For prescription drugs, I feel like people have a good understanding of what that looks like, the prior auth process. An example of a service that might require prior authorization would be an advanced laboratory testing or advanced imaging testing like an MRI. Or a supply that might require a prior authorization process. Think of something like a CPAP machine for someone who has sleep apnea. If that prior authorization process is not completed, then the health plan may deny coverage for that claim. And the way that a member would determine whether prior authorization was required for a service that they had been prescribed or that was ordered by their provider would be by reaching out to the carrier. So for UMP, you can go to the website and there is a link that you can click on that provides a detailed list of all of the services and supplies that require prior authorization. There's also another link that you can click on that takes you outside of that website to the pharmacy benefit, and that provides a list of all the preferred drug lists and the different tiers. And you could also call the carriers to get that information as well. Next slide, please. So this slide goes over the why behind prior authorization. I think most members think of prior authorization when they run into a problem with it. So when additional information is needed or they're not able to get access to something that was prescribed or ordered for them, that's when prior authorization comes to mind for most members. And people don't realize that there is a underlying positive outcome for member goal that's driving prior authorization when it's working in the background seamlessly. You don't know about it. You only know about it when it's causing what is perceived as a barrier. So that first bullet point really gets at what are those positive outcomes that we're trying to drive with prior authorization. And it's safe, effective, and high value services and supplies and medications for all members. That next bullet point talks about cost, and that is a part of determining what prior authorization, when it should be applied. I think people think of cost in terms of just the health plan itself, but it's important to remember that we're all impacted. Every part of the healthcare system is impacted by high costs, including members. And that's reflected in the premiums we pay, in our deductibles that have to be reached, as well as co-payments and co-insurance for the different services and medications. And then the final bullet point on the slide just delves a little bit deeper into how do we determine what we are talking about when we're talking about safe or effective. So we want to make sure that medications and services before they're approved are actually medically appropriate. So they're being used in the circumstances in which they've been approved for and for the right patient populations. So sometimes you hear the concept of right patient, right time, right location. And you also want to make sure that it's proven as effective, not only for treatment, but also for diagnosis. So sometimes there are laboratory tests or imaging tests for medications that have been approved, but for specific indications, and they can be used in other circumstances in which they would be inappropriate. One thing that I didn't touch on the first slide that I'm thinking back to is it's important to realize that prior authorization is a process that's used by all health plans. So this isn't specific to PEB and SEB health plans or the carriers that PEB and SEB uses, but every health plan uses that prior authorization process. Next slide, please. So when do we use prior authorization? It's not a process that's applied for every single medication that someone would seek or for every service or supply. And I think it's important to recognize that it's never applied in an emergency situation. So when you are going into the ER and you're having lab work done or medications ordered, or if you needed an emergent surgical procedure, prior authorization would not be a process that would be applied in that situation. So when do we actually use it? One of the most important things is when there's been an identified hazard or risk for the member. So that might look like certain patient populations that are at high risk for side effects from an intervention or a medication, or if there are negative interactions that would occur between different medications that someone would be prescribed. Those would be instances where prior authorization would be appropriate. As we touched on the previous slide, high cost is another factor. I think there is a general belief that high cost equals high quality. That is not true in healthcare or outside of healthcare as well. And I have a personal example from my own family where prior authorization helped drive my husband to a equally effective, lower cost medication. So my husband has asthma, and he was prescribed a new medication, which is a controller inhaler. So that's a medication he would take every day to prevent symptoms. And when he went to the pharmacy to pick up his medication, he discovered that the prior authorization process had not yet been completed, and that the cost of the medication was $1,200 for a 3-month supply, which he thought seemed high, which was an accurate assessment. And this whole experience for me was very eye-opening because I'm a pediatrician. Asthma is a very common diagnosis in the pediatric population. I prescribed many controller inhalers over the years, and I recognized that I had no idea what any of those different inhalers cost. And that is the case for many physicians or other providers that are providing care. The focus is understandably on taking care of the patient. It is impossible for providers to have an encyclopedic knowledge of the cost of every lab or medication that they might order. And that's where the prior authorization process can be working in the background, providing some guardrails to make sure that there aren't equally effective, lower cost options. So in the example of my husband, he had a new prescription that was written for a generic controller inhaler that is as equally effective, much less expensive than the initial medication that we prescribed, and that has worked well for him for the last several years that he's been on it. The last criterion that you would apply a prior authorization process for would be when a certain medication or service is only appropriate in certain patient populations. So think of a medication that's approved for adults, but then someone's ordering it for a pediatric patient, or a intervention or test or medication that is for a particular condition and that someone's trying to use it outside of that approved indication. Next slide. So to sort of wrap up all of those what, why, when indications, what are the overall benefits of prior authorization? Just to kind of drive home some of the points. We are really looking to reduce costs for members by directing them not to just things that are lower cost, but making sure that those things are equally, if not more effective, before they have more invasive or unnecessary things done. So a good example of that would be for an elective knee surgery. A common prior authorization criterion is making sure that a member has had physical therapy. In some situations, physical therapy would improve their symptoms and pain and avoid the risk of a more expensive and risky surgical procedure. As we've talked about, we want to make sure that medications or labs or imaging that are being ordered are appropriate and safe for that patient or member that's getting those services. And we didn't talk about this yet, but preventing fraud, waste, and abuse is another guardrail function of prior authorization. So the vast majority of people in the healthcare system are trying to do good things for the members and patients that they're taking care of. But as with any system, there are always a small number of bad actors that are able to take advantage of what is a complicated reimbursement system in healthcare for their own financial gain. This is prior authorization as a way to monitor that. And then there's unintentional waste. Again, referring back to that example with my husband and his inhaler, his pulmonologist was not trying to drive up healthcare costs by ordering a much more expensive inhaler that wasn't more effective, but prior authorization can catch that.
Trying to formulate the question again, sorry. Has there been any type of kind of equity analysis that's been done with regards to like assessing around like medical necessity? And like the thought that's coming to my head right now is around when Kate mentioned earlier around like kind of hormone replacement or hormone therapy, and kind of how traditionally for like perimenopausal women that's been seen as optional rather than having kind of like a health impact for people who are experiencing it. And so just again, I'm not sure I know the question yet, but just like as I'm reading through it, it logically makes sense unless you're part of a population that doesn't fit into kind of that normal mold of like, oh yeah, that's medically necessary when it might be for them. If that makes sense.
Yes, that does make sense. I don't know. I need to think about the answer to that. Are you asking if there is like a more formal process that health plans use to compare outcomes or different populations of their members and how prior authorizations apply?
Yeah, or just like I think it's the, you know, what are health plans doing? And then my guess would be maybe not a lot yet. And is there anything again that we can do as a very like large influencer to help medical plans understand that we care about the people who might not have been seen traditionally and how we assess whether or not something is medically necessary.
I can speak to that a little bit, at least from the pharmacy side of the house. So you hear a lot medical side, pharmacy side over here. As far as pharmacy, we do look at, meaning HCA and the MODA third-party administrator that administers our pharmacy benefits. We often look at clinical policies and coverage criteria. We update our preferred drug list monthly. The clinicians, specifically CEDL at MODA Health, they're always working at looking at new and emerging drugs, but not just new and emerging drugs, but new and emerging indications for drugs, and gaps in care, right? Where we may see that maybe certain populations aren't getting the drugs that they need for, like, women, perimenopause and menopausal symptoms, like you mentioned. So we're constantly updating policies. We're constantly updating our preferred drug lists with the intent of serving populations more. And Luke and CEDL work very closely, continuously, to address any gaps and make changes. So we're always looking at drugs that are entering the market. And when we do that, when we do the policy updates or we do the preferred drug list updates, that's when it's decided whether a prior authorization is necessary or not. And I'll get into this, I can skip it in my slides later, but we sometimes prior authorization is no longer necessary. When we're reviewing those clinical policies, sometimes it's determined we're overturning a lot of these denials, and maybe there used to be, just this one drug that was indicated for this service and it was a high cost, it was high risk. Well, now, clinically it's been reviewed and that drug is no longer a high risk drug. Is prior authorization needed anymore? We do occasionally remove prior authorization when it's necessary. Is that?
Yeah. Okay. I think there's parallels with medical policies as well, outside of just pharmacy. Certainly the plans look at not just, as Jenny was describing, new literature about indications, but they also look at the appeals that they get, as well as the results when they have an independent review organization do the review. If they're seeing a pattern of things being overturned that they had initially denied, that sometimes is a trigger for them to look at the policy. So those are probably more one-off than a formal equity policy in place, but the intention is to make sure that there aren't groups of members that are being treated unfairly.
But I guess what I would just comment too, though, that applies to active employees, not retirees, because they're going to be going through Part D if they're in uniform. So I think it's just remembering that there's two different perspectives.
I will just close out this slide by touching on prior authorization renewals, which are sometimes a point of confusion and friction for folks because they think, okay, I have already got prior authorization for this medication or for my physical therapy or for some equipment that I'm using. Why do I have to do it again? And again, we are driven by a goal of making sure that we're providing appropriate treatment for our members. So things change over time. A new treatment may be available that wasn't available when the prior authorization initially was put into place. Or a member may have developed a new medical condition that would make the use of that therapy not as safe anymore, or is on a new medication that would have drug interactions. So although it can feel like an additional hurdle for people to get over, that is put in place again to support members having positive outcomes. Next slide.
Okay, over to me on these ones. So oversight of prior authorization, as I kind of alluded to when I answered Michaela's question earlier, we do review prior authorization requirements, clinical policies, preferred drug list continually. And it's not just reviewed at a healthcare authority, it's not just reviewed at MODA. There are medical policy committees for the medical services that get together to review coverage criteria, including PA. And then there's pharmacy and therapeutics committees. for, if you're curious, last year Luke did a really good presentation that included a section on P&T committees and their role and involvement in reviewing coverage and all the things associated with that. And I mentioned policies are evaluated annually or when additional clinical data is released that warrants that reevaluation. So a new indication, a lot of times a drug will hit the market, it's for a very specific treatment, and all of a sudden it's just discovered, oh, this also treats irritable bowel syndrome. Maybe we need to reevaluate it for coverage for that. And so those evaluations of the policies are taking place at least annually, but as we generally see, it's a lot more often than annually. It's really outdated. And like Dr. Schultz mentioned, if we're seeing a lot of returns of prior authorization denials, it really cues us into, we get those reports at HCA, MOTA reviews them or Regents reviews them, we get them, and then we review them and we say, this is overturned this percentage of a time, let's look at this. So we do look at those really often. And then, like I mentioned before, often that requirement for prior authorization is discontinued if it's no longer necessary. The next slide. So this has come up, I think people have questioned, I think the board questioned this and asked for more information on it. Why are we seeing increases in prior authorization legislatively? And the truth of it, and Dr. Schultz can speak to this, as a physician, prior authorization can add administrative burden, right? And so we hear a lot from the provider community about prior authorization and how sometimes it can be seen from their perspective as burdensome, because it can be. Prior authorization, it's time sensitive, right? We'll go into some of the timeliness of prior authorization in an upcoming slide. And so these providers are expected to send out prior authorization requests for the members. And then that turnaround time is pretty quick to try to get the care to the members in an appropriate time. That sometimes requires additional staff at the provider's offices to handle these prior authorizations, get them submitted, and then review the approvals or denials as they are received back at the provider's office. And so that can create delays in delivery of services. There's also that part, Dr. Schultz mentioned, her husband going into the pharmacy and the prior authorization wasn't entered into the system, which created a little bit of a delay, a good delay in their situation because it saved them a considerable amount of money, but it can create a delay in getting those medications or services if that prior authorization hasn't been entered into the system appropriately. And that's why we do have language in our contracts with our third-party administrators. There's also state laws we'll see here in a slide about turnaround time and getting those applied quickly. So the next slide, let's look at these recent law changes. So RCW 4843-0161, also known as House Bill 1357, that made some changes to prior authorization. So effective January 1 of 24, it required shortened processing times across state regulated insurance plans for medical services and prescription drugs. So what it did is it reduced the prior authorization turnaround time to an annual average of 1 calendar day for urgent requests. This used to be 1 business day for urgent requests. It's now calendar days. So additional staff had to be added at the third-party administrators to be able to handle these over the weekends. And then an annual average of 3 calendar days for those non-urgent requests. And then this bill or this law also has language in it that effective January 1 of 26, it requires those insurers or third-party administrators to have APIs, application programming interfaces, that connect to electronic health record systems. And that will just create more of a streamlined process to help make sure that they are moving through these prior authorizations quicker for our members. And then on the next slide, here is a little bit more information, because that what I just went over was the state regulations on turnaround time to prior authorization. Centers for Medicare and Medicaid Services, CMS, they also have a final rule where effective January 1 of 2026, there has to be a standard case turnaround time of 7 days. I think it's 7 calendar days for the standard cases and 72 hours for urgent cases. So as you can see, if you compare the two slides, Washington State is already well ahead of where CMS is headed. And then they also, effective January 1, 2027, so a year after we have to have it in place, plans have to allow for that exchange of patient information with payers. Next slide. I was going to say, I think that brings us to the end. So we've gotten a couple of questions. What additional question?
I have a question about fraud. When I was doing my doctoral program in healthcare administration, we had a case study, and the study was about doctors prescribing medications for the first time, and instead of say a 30-day supply, they'd order a 90-day supply, and then the patient would only be on it for a week or so, and then say, "Well, it's not working." So that there's no mechanism for returning those pills anywhere. I'm just wondering if that's ever been an issue in terms of waste.
It's definitely something that's looked at. And so I think Dr. Schultz mentioned that a little bit. Certain drugs, there's prescription limitation, especially when you look at opioids or drugs such as that. And so those prior authorizations, the clinical protocols for those drugs do have limitations. There are certain drugs that, and we didn't talk about this, but there are certain drugs that there's not great adherence for. And so really what you're talking about is that adherence. You get 90-day supply, you only use it for a couple weeks, that's a waste. Not only does it create waste in our systems, if you're flushing it, please don't flush your drugs, but it creates waste for our members and for the plan. So we do have limitations on certain drugs. Especially, we do look at the adherence of drugs. So some limitations on what your fill can be. And we run actual programs with, specifically for drugs with Moda Health, we run pharmacoadherence programs where we look at drugs that may not have a very good adherence rate, but they're important. Right, those controller medications, insulin, things like that we know if you're adherent to it, you are going to have better health outcomes, and it's going to drive down the overall, not just cost of care for you, because hopefully if you're doing your controller medications, you then wouldn't need as many ER visits, but also for the plan, it pulls those costs down. So we run programs to pull data to see if there's certain drugs or services that people aren't being adherent to. And then we do occasionally reach out to members to say, hey, we've noticed based on your records that you haven't filled this or you've had inconsistent fills with this. This is why this medication is so important to you and your long-term health. And then the doctor is also notified, hey, you may want to touch base with your member. There's great cases where adherence, where we see they don't have adherence, and that's wonderful because they no longer need the drug. But we do try to look at ways of driving down costs and improving member outcomes by focusing on adherence.
Actually, my question wasn't so much about adherence, was about prescribing. For instance, on a new prescription, to have the prescription for 30 days rather than for 90 days, to see if the patient would tolerate or that would be the best prescription. I've seen it in real life as well as in a case study, where particularly an HMO would have a doctor prescribe whatever they wanted to prescribe, and then make several changes over the course of the first 2 or 3 months of the patient's visiting. So all of those medications are wasted because there's no mechanism for recycling. And it just was driving up costs dramatically. So I'm just wondering from our perspective, and maybe from a larger perspective in terms of healthcare policy, has there ever been a recycling effort for medications?
Well, I did catch the nuance of your question versus how Jenny answered it, and I think we'll pull some data and see what we can bring back about it. And then we can also at the same time talk about, I know our agency has had partnerships on, and there are drug cycle return programs, and so that seems like a good topic that we can incorporate at the same time. So I'm just gonna ask to put a pin in it, bring more data back when we have a little bit of time to look at it. I think that's a good data question for us to look at. I saw Tom's hand up.
Yes, thank you. On slide 4, it says services or drugs are high cost, and this is when prior authorization applies. Services or drugs are high cost, and there are effective, clinically proven alternatives available. I'm wondering how many, oftentimes there are more than one clinically proven alternatives. How many would you have to try? Is there a limit before you could try the original drug that perhaps you were prescribed by your doctor?
Yeah, so that's, we call that step therapy, and it's really, it's determined by the policy for that specific drug. So certain drugs do require you to try alternatives before you can get a prescription filled and covered for, you know, a certain drug. So
but
it's very, oh, go ahead.
Well, is there a limit though on how many you can be required to try?
It's based on the drug.
Yeah, I think it would vary by what type of medication and what condition. And I think there is a judicious use of step therapy where the idea is making sure that you have tried different classes of medications. Like you wouldn't necessarily require somebody to run through every single type of drug that's in the same class, and there would also be different, I mean, every step therapy policy is going to be slightly different, but things that are taken into consideration are not just running through every possible medication that exists that's different from some more expensive medication, but also what are the different impacts that the medications that you've tried are having. So I know that's not I would say it's not a one size fits all approach for step therapy. It's very specific to each condition and medication.
The reason the reason I bring this up is because I know 2 people personally that were affected where they were actually, this is under a formulary, they were given a specific drug to take to treat a particular condition, and then they were switched to generic alternatives, and the generic alternatives made them sick, and then they were switched to another generic alternative, they were made sick again, they were switched to a third generic alternative. When that didn't work, they were allowed to go back to the original drug. But that process of going through that many alternatives was very, not only time consuming, but very negatively impactful to their health. And that's why I'm curious about this. Is this going to be a condition that might have to be under similar circumstances that people will have to go through?
I think if we want to talk about a specific scenario, we could take that offline so that we can learn more details. Because I think, you know, channeling Heather here, if let's say that the drug the original person on costs $1,200 a month, and all the alternatives cost the member $25 a month. That may be a reason why there are multiple classes based on what that condition is, but without knowing more about the detail of the condition, which I don't want to get into PHI for people here. Happy to have you and Heather and Jenny talk a little bit more about a specific scenario to understand, but I think much like Tanya and I say, there's no magic number for the funding rate, there's no magic number when it comes to step therapy. But we can certainly go through and understand a little bit about the more specific scenario to see if we can help you understand why there may have been so many steps in whatever the specific disease state is that they're talking about. But I'd ask you not to share the disease state here, just to help with the PHI.
I would ask, well, I would mention one other thing, in that this was the debate that we kind of had when we were first discussing the value formulary. And when we were doing that, that was a particular concern that came up, and it was brought up multiple times by multiple people. And in each of those cases, there were people that were cited that had that problem. So I'm wondering, again, that's my concern with prior authorization, is that those kind of scenarios are going to continue to pop up because there are so many alternatives and people are being told that they have to take those before they can get the drug that might be originally most effective. And I would think that your doctor, if the doctor is the one that decides that you need that particular medication, that they would be, again, maybe in a better position to know what they should prescribe.
I think that's a factor, and then there's also the adherence piece of if Dr. Schultz's husband had a $1,200 medication and may or may not fit their budget to be able to adhere, and although that might be, you know, that they're a $1,200 medication that is not taken consistently versus something that might be, we don't know until they've taken the drug to understand if there is a side effect, might result in better adherence for managing the condition. There's just a whole lot of different factors that are just kind of very specific, case specific. So we'll definitely have Dr. Schultz and Jenny reach out to you to kind of talk through a couple more scenarios that have more specifics around them.
Well, there's just not one good answer to this one, so
Right, there
it'll
is.
take a little more time to, to develop that. So anything else? Thank you to our presenters. Great job, appreciate it. So we have now moved to the public comment time. And so it's what we'd like to first gather a list of the speakers to effectively manage time. So if you do want to speak, if you could, if you are virtual, if you could just go ahead and raise your virtual hand so we know who would like to speak. Anybody? See anything? Three, four. You have, okay, there's four now. There's Fred Yancey. Sorry, well, do you want to just jot them down and then we'll try to think of the most effective way. We'll take a list. We'll go ahead and do the room first, and then we'll come back and do folks online. So hold that thought, and let's go ahead now and start with the room. So we've got anyone in the room?
I don't think we have any.
Oh, right, doesn't look like it. So why don't we go ahead with the list, and I'm going to turn it over to Dave. Go ahead.
Sure.
Just turn it over to Dave.
Just as a reminder, as we call people's names, you'll be promoted to a status where you can turn on your camera and audio, and you won't see that until you're called on and promoted. So I'll do first up is Fred Yancey, and then Aruna, just so you know you'll be next, but start with Fred. And if you can identify your, if you're with any organizations or any, that would be appreciated.
Can you hear me?
We can hear you now, Fred. Go ahead.
Okay. Thank you very much, and thank the committee for their work this morning. A wide-ranging agenda. Just two comments and no real questions. Like Tom, I'm very concerned about this step therapy idea. I understand the inhaler example is an example that the fact that you may have to use a less effective or wait 30 days to find out that a product isn't effective really concerns me. And I know I testified previously when the committee was looking at step therapy, but I think that's an issue that bears more examination, and I'm not sure how to do it. The second thing is, what I hear from people is that for prior authorization, they're often turned down by either nurses, PAs, and then I've also read articles that claim AI is involved in making those determinations. And I'd certainly be interested in more information on who makes the ruling in terms of a prior authorization, and should legislation be proposed that regulates it more than it is. So thank you again. Thank you very much for your time and your work on the committee, everybody.
Thank you, Fred, for your comments. We'll move you from presenter status. Aruna, you'll be brought in, and then next up will be Robin. But Aruna will confirm for you once you, just for those who haven't experienced, it's a little jarring. It has a few second delay. Looks like you're being kicked out of the meeting, but you're not. Fortunately, it's just part of the process. But Aruna, you are up.
Okay, I am unmuted. Thank you for a very informative presentation by all the speakers. My question is around prior authorization. Do we have any data available about what % of services and drugs that needed prior authorization in 2023-24? Are we seeing any trends?
Thank you, Aruna, for
And
I won't answer that question now, but I will take that under advisement as something that could be of interest to folks. So.
Yeah, and sorry, I forgot to identify myself. My name is Aruna Bhuta, and I'm from Spokane, and I am part of RPEC, Healthcare Work Group, and on Legislative Committee. Thank you.
Right. Thank you for that suggestion, Aruna. We'll take that under advisement. We will move on to our next public commenter, who is Robin. So you'll be promoted. And then last up after Robin, we will move to Kent. But Robin, we will zap you into presenter status.
Okay, now can you hear me?
We can. Please proceed.
Okay, sorry about that. I am asking about something completely different. I'm not representing any particular group with this question, but I just received a notice from PEBB, I believe, that Swedish and PEB were leaving Regents. So I'm concerned about what's going on with Regents because at first, polyclinic providers left Regents, and I thought, well, they were purchased by Unum, so I figured there was something going on with that. But now Swedish is a very large group, and so is PEB, and a lot of my providers are with them. One, were they able to renegotiate their contract? And two, will we be expecting more people to drop out of Regents?
Robin, I don't normally engage a lot on public comment, but I wanted to share some insights. At the very beginning of the meeting, I talked a little bit about this particular network dispute.
Okay, yeah, I missed that.
No, that's okay. But I think it's an important one because it is kind of a very urgent, hot topic among the community right now. I'll say we do have a news announcement that's on HCA's website. If you're on the main page and you look in the bottom left corner, there's a news section, and we have a link where we're providing information about this particular network contract negotiation that is still ongoing. The contract doesn't end until the end of this month. And so the parties are still negotiating for a potential new contract that would be in place as of April 1st. Although we can't guarantee any specific outcomes, the vast majority of times the parties reach an agreement before the network termination actually goes into effect. But there are state legal requirements for sending out notifications about the upcoming potential disruption. And those are the letters that people were receiving, like the one you referenced. Real quick, when you mentioned that there was a dispute between Regents and Polyclinic, for UMP at least, they actually did reach agreement, and Polyclinic never had a disruption, nor the Everett Clinic. They did not reach agreement on a contract that doesn't impact the PEB plans, but they did reach agreement on the PEB contract. But this is a very similar scenario where this is since the pandemic ended, there is a more frequent cadence of these network disputes that are going to the 11th hour, if you will. It causes a lot of, hopefully in the rearview mirror, unnecessary angst that is very understandable for people. It's not specific to just Regents. This is happening with various hospital and large provider groups in different parts of the state with different carriers. So it's something that we're trying to make sure people are aware the consumers are put in the middle of this unfortunate situation. I want to assure you that we at HCA monitor the negotiations with Regents that does that work on behalf of UMP, but it isn't something that's Regent specific, and it's not specific to any one provider system. It is an unfortunate piece that even the legislature is looking at possible management or different rules around this entire process. services that members receive through the end of the month are still in network. And I would encourage you and others to kind of bookmark that news announcement that we have on the HCA website, because the information can change more quickly than we can send physical letters out from HCA about. And we update that news link when these scenarios happen at different points of the years on each of the network disputes that are occurring. And that will be the fastest way that you will hear that an agreement has been reached, if one indeed is reached. Often in these scenarios, one is reached, and it's usually the last few days before the termination would actually go into effect, or even the very last day. So hopefully that's a little bit of context for what the situation is. I know it's unnerving, concerning, frustrating, scary, especially people who are in the middle of care, let's say a cancer treatment. There are also protections for being able to pursue continuity of care as if the service is still in network. If a dispute actually happened, we're still several weeks away from that occurring. Under my tenure, there's only been one network dispute that actually went to termination, but both parties previewed a year and a half in advance that they were really going to separate. All the other instances have ultimately reached a new agreement. So I appreciate you bringing the concern. Anything you could do to help you and your friends and family understand and look at the HCA website for that news announcement, I think would go a long way to helping calm some nerves, if at all possible, in what is an inherently stressful situation. And I'm sorry that you and everyone is in the middle of it.
Thank you.
Yep, and then thank you, Robin. And now we move on to our last public commenter, who is Kent. We will zap you in. It's just the movement process.
Okay, there I am. All right. I want to go back to prior authorization. I think it's one of the biggest, most important issues there is today with health insurance. From what I've seen, my name's Kent Questhead. I'm in Chapter 3. I'm also on the healthcare work group. I want to thank you for the great presentation about prior authorization and the reasons for why it is in place. But I just wonder, it seems like most of the things that are listed there are testable empirically. I mean, you could, and because it's so important, I really think it should be something that you're gathering data about. Like, the biggest assumption is people get better and less expensive care if somebody else is evaluating what the physician or the primary person is deciding. And as I say, that's all numbers for the most part. It's something that could be studied on many different levels. And I think the biggest thing that raises my concern is that many plans have very high reversal rates with appeals. So when you see that merely bringing it up to review causes a different decision in like 70-80% of cases in some instances, you really have to wonder if that whole process has validity other than reducing the amount of money that goes out the door initially. So I just wanted to know if there's any ongoing evaluation of the validity of the whole process.
Thank you, Ken. I'll say similarly to Aruna's suggestion earlier in public comment that these types of data things are things that we can take under advisement to talk about in the future. Can you clarify? You said you're Chapter 3, but Chapter 3 of which organization?
RPAC.
RPAC. Okay. I didn't want to just assume. Thank you.
All right, I think that's it. That's it? All right. Well, I want to thank all the participants today, thank our speakers, our presenters. Great meeting, and our next meeting will be April 10th at 9 o'clock. Same format of attendance in person or via Zoom. And Dave, do you have any comments before we adjourn?
the preview of coming attractions. We'll have legislative budgets by then that Tanya will walk through. We'll continue an update about benefits 24/7. I think we will have a PEB policy resolution be introduced for consideration and vote then in May related to eligibility and enrollment policies. And those are just a few of the things that are on deck. So just like to give you a preview. That's it.
Again, thanks to all.